Everybody, at least here in India, good afternoon in UK, and good morning, good night, wherever in the world you're logging into this great presentation here. This myself, Dr. Pawan Gorakanti, myself, I'm a pulmonary critical care doctor, mostly in the US. My mother is New York. Since 2018, I relocated here and looking into administrative stuff here in Yashoda Hospital, a single city-based hospital in Hyderabad, South India. We are the leading healthcare provider here, about 2,500 beds, including 350 critical care beds. We're building a new one in high-tech city, 2 million square feet facility coming up shortly in a year or so. Here in India, we have been through this second wave a little. Nobody expected this kind of wave, and everybody here is super busy. And it's a great effort by Dr. Hari here to get we thank everybody from the UK, Dr. Rakesh. I think thank you specifically for organizing a great session here, right in the middle of the. I mean, we are kind of towards the tail end of the pandemic here. At least the case-wise caseload seems to be decreasing in most of India, particularly here in Hyderabad and Delhi and most places. Still, we are stuck with those sick people. The mortality is still on the higher side because many patients are on ventilators. This is a little new and unusual in India. That air ambulances seem to have picked up here. We had more than, I think, 55 air ambulance transfers in the last 2 months from all over the country. I think right now we have 10 ECMOs running today. We had a few of these lung transplants. A little more about that. Dr. Srinivas, our transplant pulmonologist, will talk about this ECMOs and his experience with the COVID transplants and ECMOs and acute care situation here in our hospital here, Hyderabad. So Leicester City, I think, I'm not following the EPL closely, but I think they just missed out on the Champions League, right? So maybe the people are past that, and at least Europa League or something is good enough too. So we'll concentrate on the pulmonary and other stuff where I think you guys are leading light in the UK. So I think it's better we have these kind of interactions so that everybody gets benefited by this mutual exchange of ideas. And a special thanks for Dr. Woltman for his inputs about epidemiology, Dr. Halder, Dr. Steiner, Dr. Evans, Dr. Sampson, Dr. Arjun Khanna, our own Arjun Khanna from Delhi will definitely start off the session with a good enlightening session about the second wave in India. Dr. Nitesh Gupta from Delhi also will talk about a little bit of the past and future of the COVID pandemic. So at least the good part here in India is I think this second wave, I did not expect this kind of a big wave, but number of new cases seem to be decreasing. They're still stuck with the old cases, particularly the sickest ones in the tertiary care center. We see those cases. But now, I think we have a little more clarity in guidelines because it's almost 2 years now. So all these medications, just now, I think Harikishan's patient, we are giving this, the cocktail, the antibody cocktail made famous by Mr. Trump when he received that. We received that here in Hyderabad today, and Dr. Hari's patient, as we are speaking, I think is receiving that. We have this Mopilavir also, we recently were doing a trial research here. But most of all the other medications are available here. Without taking too much of everybody's time, I'd like to thank everybody, Dr. Hari, Dr. Rakesh in particular, for organizing this great session in between this kind of crazy pandemic here. Hari has more than 100 to 150 patients every day. Despite that, able to organize this session. So I hope people, budding pulmonologists, critical care doctors, and whoever logging from all over the world, please make use of this great sessions. This will be on YouTube too, so you can view at your own convenience, and all the panel will be there towards the end of the session to answer any kind of questions, and this was a great session, and established guidelines, because in the absence of a clear-cut established guidelines, these kind of interactive sessions from all over the world will benefit patients from all over here. And if some third wave or something develops in other parts of the world, they will also be benefit. So it's great. And Dr. Pawan Gorakanti here signing off, and here Dr. Hari and Dr. Rakesh will guide you through the rest of the session. Thank you.
Thank you, Dr. Pawan. I'm just going to share my screen. Can you all see that, Hari? That's great. So good evening and a warm welcome to colleagues in India, and obviously to people listening at home and around the world on YouTube. My name is Rakesh Panchal. I'm a respiratory physician at Glenfield Hospital, which is part of the University Hospitals of Leicester here in the UK, and we're one of the largest acute respiratory trusts and have managed a number of COVID patients over the last year, and we're one of the highest recruiting centres to the UK-based COVID research studies. I'd like to thank Dr. Hari Kishan, my co-chair, for inviting us to host this webinar in collaboration with Yashoda Hospitals in Hyderabad to try and share some practical tips on management of COVID from the UK perspective, because there's a wide variation in practice, and we thought it'd be nice to sort of put a session together. So I've just got a few slides before we start the program. So COVID is not going anywhere anytime soon, and the COVID pandemic is continuing around the world, and I think we will reach an endemic phase at some point, which is going to keep us busy for some time. In the UK, as you will have all heard, we had our second wave sort of towards the end of December, beginning of January, and that was mainly thought to be due to this Kent or UK variant. As we know, viruses mutate, and this was the most common mutation that we've seen, and which led to our second peak. So rates have sort of gone down now, and this led to our second lockdown at the beginning of sort of January. And as you'll have probably heard, although the UK variant is still the common one here, there's concerns about the Indian variant sort of potentially taking over, and we'll hear a bit more about that through our program. So our second lockdown started in January, and there's been a slow sort of easing of restrictions with which have been happening every month. And last week, you were able to start meeting people indoors, and restaurants and pubs and everything were open. And the plan is by the 21st of June that all limits on social contact will be gone. But obviously that depends on the data and what happens. And obviously the current situation with the Indian variants in the UK may well lead to a third peak slightly earlier than anticipated, potentially. So this is the UK government dashboard from yesterday. And as you can see, we've come a long way since January. And in terms of, I think one of the positive things is vaccination has been prioritized, and almost 3/4 of the adult population have had their first dose, and we delayed the second dose to try and get more people to have their first dose, and just under a half have now had their second dose. And obviously vaccine has been rolled out and prioritized in many areas, especially where the Indian variant is of some concern. So we've all been sort of saddened by the harrowing and quite devastating consequences of the second wave in India. As you'll all be aware, the UK has a large Indian diaspora, including here in Leicester, and many of us with close ties to India have had friends and family who have suffered or been lost to COVID, as I'm sure you have. And these sorts of pictures we've seen of Indian hospitals being overwhelmed, lack of oxygen, access to oxygen, and obviously difficulty in people completing the important funeral rites. And obviously what we've heard about is the new mucormycosis epidemic has all been quite distressing. I think it's important to note that the world is a small place. And as it says here, India's crisis is everyone's crisis, and no one's safe until we're all safe. Dr. Swaminathan, who's one of the WHO scientists, had this quote saying, obviously the virus clearly doesn't respect borders, nationalities, age, sex, or religion. So I think we're all in this together. On a positive note is this Public Health England study, which came out at the weekend, which showed that 2 doses of either Pfizer or the AstraZeneca Oxford vaccine are highly effective against the Indian variant, which is circulating in the UK. And there were some concerns about vaccine efficacy against this. And it's shown that there's only about a 20% drop with the first dose of both vaccines and about 5 or 6% after 2 doses. So that's good to hear. For those of you who are members of the Royal College of Physicians, you'll probably receive this weekly email from Andrew Goddard, the president, and his bulletin from Monday actually was quite interesting. He mentioned that there was a vet who follows his bulletins, and he sent him this article from Clinical Microbiology Reviews about 14 years ago, which looked about the emergence of coronavirus. And in the last paragraph, he quoted that we need to be ready for the re-emergence of SARS. And I think the killer line there, he said, was the presence of a large reservoir of COVID-like viruses in horseshoe bats, together with the culture of eating exotic mammals in South China, is a time bomb waiting to blow. And obviously, we're in that pandemic right now. So I thought that was interesting. That was mentioned about 14 years ago. On another positive note, some of you may be aware that the UK Research and Innovation Council, together with the Indian Department of Biotechnology, have pledged £5 million to gain a deep understanding of COVID in South Asian populations, both in India and the UK. And there's 4 streams here looking at potentially the role of immune activation in cardiovascular disease. What are the determinants of COVID severity in South Asians in India and the UK? And also whether the oral microbiome or mucosal immunity might be implicated. So without further ado, this is our programme for the afternoon, and we've got varied topics with excellent speakers from here in Leicester, from Yashoda and from New Delhi. And I'll hand over to Dr. Hari Kishan, my co-chair, to introduce the first speaker.
Hi, good evening, everyone. Thanks to the faculty from the University of Leicester for accepting our invitation. The first lecture will start with Dr. Ajay Khanna. He is the Senior Pulmonary Medicine Specialist at Yashoda Super Specialty Hospitals, New Delhi. He'll be taking us through what's the difference between the first wave and second wave in India, and how are we dealing with it, and what are the current strategies we are trying to control the second wave of COVID. And over to you, Arjun.
So, thank you, Hari, and thank you, Dr. Pavan, for inviting me today. It's always a pleasure working with you guys, and I hope you can see my presentation. So, I'll be taking you through the second wave. I prefer to call it a tsunami. It was not a wave. It was bad, and thankfully it is going down. And no conflicts of interest in this presentation. This is just the opening of this fantastic series. I'm really looking forward to all the lectures. So this will just be an introduction or an informal update on what has been happening in the last couple of months in India, what we have been going through. I'll just be thinking out loud. I'll be summing up the last 2 months of my life, which have probably been the most difficult, times that I've ever, or all of us have ever been through. So I work in a 300-bedded tertiary care center in Delhi. August to November last year, 2020, we had around 300 COVID beds. So the whole hospital was basically a COVID hospital, and we had 100% occupancy. January, somehow, something just happened. Someone just pressed the off button. The numbers drastically went down, and everything just felt okay. Feb 11th, this year, we discharged our last patient, and we thought this was the end of it. The vaccination program, especially for healthcare workers, had started in India January end, Feb mid. And, we thought that the storm had passed, and we were extremely happy. Now, in a country like India, when the daily case rate was only 11,000 cases per day, it was actually nothing. And from, more than 2 lakh cases per day, we had gone down to 11,000 cases per day. So it was all very rosy, and we were all actually quite happy this January and Feb. Early March, there were these reports coming up of, cases increasing in Kerala and Maharashtra, that is the south and the western part of India. And because there's so much of to and fro motion between UK and North India, that is Punjab and Haryana. So 80% of what was being reported from Punjab and Haryana in Jan, Feb was the UK variant or the Kent variant. They had also picked up this, what is now called as the Indian variant, the B1617. It was picked up in December, And it was postulated that this variant is going to be more infectious than the other variants. Unfortunately, it was spring season, and it was the festival season. Holi was around. A lot of, festivals were around. School sessions had ended. Children wanted to come out of their houses. Everything was almost open. It was the time of financial closing. The market had a very bad year last year, so everyone was trying to, really make it up. So everything was open. There were no lockdowns, there were no restrictions. Everyone was back to business. The social distancing had gone for a toss. There were 2 vaccines available, Covishield and Covaxin. The AstraZeneca vaccine, there was a lot of negative press associated with Covishield, that it causes blood clots and whatnot. And a lot of our patients were not really, or even the doctor fraternity were, kind of skeptical about the Covishield, because there was this talk about clotting. And then Covaxin was an Indian product. We as Indians, we really don't believe in anything made in India. So people who were being offered Covaxin were not really happy taking Covaxin. So people had problems with both the vaccines. So there was some amount of vaccine hesitancy, and I think that added to our problem. So March 28th, this is my data from my hospital, we had 11 patients of COVID. Feb 11th, we had discharged our last patient, but by 28th March, we had 11 patients. Within the next 3 or 4 days, rose up to 67 patients. And from April 2nd to April 12th, we are a 300-bedded hospital. There were no beds available on the 12th of April. On 16th April, we were using the floors of the hospital. We were using folding cots to provide help to whatever patients we could. And a 300-bedded hospital was serving 385 COVID patients. Remdesivir was out. We had to ration drugs like IV methylprednisolone, dexamethasone, which are dirt cheap drugs. And I had never thought in my life that we would actually have to ration these drugs for our patients. The availability of blood thinners, enoxaparin, dalteparin, all these were rationed. Whatever we would have our hands on, whether it was NOACs, the oral agents, or, whatever was available, we were using those. There was oxygen crisis, there was staff crisis, people were falling ill, the hospital staff was falling ill. And that was, when we sensed that this is going to be really bad. The next couple of months were going to be difficult. So what was different this time? There was an explosive rise. And this was, attributed to the new variant, which was called as the double mutant, which is a misnomer. Unfortunately, there was a very high RT-PCR negativity. So people would get their RT-PCRs, and with the negative report, even though they had classical symptoms, would come up and tell you that they do not have COVID. And then the rapid antigen test, which is so prevalent in India, and everyone is very fond of doing the rapid antigen test, especially in the peripheral areas. People would do the rapid antigen test, which was for the new variant had a sensitivity of only around 50 to 60%. So we were missing 50-60% of the patients if the RAT was done. And people would, freely roam around saying that the rapid antigen test is negative. Unfortunately, this time it started in a lot of patients with atypical symptoms, especially in the younger population. People were having diarrhea. There were no respiratory complaints. They were coming up with, pain abdomen and whatnot. So a lot of these people were missed out because of that. This time around, there were more ICU admissions. Even as of now, when I speak, the real problem even today is the ICU admissions, more people getting sicker this time, and unfortunately, more younger people getting sicker this time. Is the disease less steroid responsive this time? Well, I don't know whether the statement is correct, because somehow this time it's more difficult to treat. Last time we were very confident. Last year, it was more steroid responsive. Patients were doing well. A lot of these patients, majority of them were managed in the wards or in OPD setting. But this time, despite giving them decent doses of steroids, the recommended doses of steroids, they are landing up in the ICUs. The mortality is definitely higher. This time around, we have the more stuck up COVID phenotype, which is the long COVID phenotype. We, today in my ICU, we have patients who are now in the ICU for more than 58 days, 50 days, 42 days. So the list it goes on and on. And of course, the new problem of mucormycosis, this new terrible thing which has come up, is really causing sleepless nights for all of us. So, the 2 countries with the most dubious distinction of having the highest case loads in the world, India and US. Now, US, you look at the blue graph over there, they had their second wave, last year. And what we are having right now, the second wave, was comparable to the third wave of the US, which they had, like UK, early January and Feb this year. So our second wave is mimicking their third wave. And that is what really scares me, that probably, you know, in the next few months to come, as is being postulated, we might see another wave. And if you look at the comparative numbers between the number of cases in the second wave that had stuck the US and what we are going through right now, look at the orange bar there, which is the Indian graph. The number of cases is substantially higher than what was seen in the US in their second wave. And if you talk about the mortality, the death rate in the second wave in US, the areas like New York City, where there were majority of deaths, even then the number of deaths per day was around 1,000 per day. But in India now, in majority of the cities, especially during the peak that we had around 2 weeks back or 1 week back, it had easily crossed more than 2,000 mortalities in a large part of the country. So that is something really alarming. The number of deaths that we've had with this peak has been really terrible. Now, if you look at this is from the Indian government, the dashboard, the number of cases, the 7-day average cases this time around has been extremely high. And mind you, you know, in a country like India, when they tell you that the number of reported cases in a day in India is 240,000, these are the patients who have been tested. Multiply that by at least 10 times to have the actual number of cases that you would have in a country like India. And this is for Delhi. Delhi per se, you know, it's a very small city, but it is a very dense city. So in a city like Delhi, at the end of April, the actual number of cases that were being reported was 27,000, 30,000 per day. But I think the figure was much higher because these were the cases which were RT-PCR proven. Had they taken into account patients who were diagnosed by other clinical methods or patients who were diagnosed based on radiology, I think the number would have been much higher, because in India, this bias would always be there that we would not really know the actual number of cases. And if you look at the mortality, this wave was particularly notorious in causing a lot of mortality. Last wave, the highest number of deaths per day, which was ever reported, was the tune of 2,000. And we've all seen that the last wave, we were able to help a lot of these patients. But in this wave, in the last few weeks, the 7-day average mortality around the first week of May was around 4,000 deaths per week, which is alarmingly high. So just to report from ground zero what was going on, you know, first week of April, we were talking to my residents when, you know, it had started coming in. We were talking how bad, you know, can this be? We know how to manage this. We've already seen one wave, and majority of our patients, we did very well with at least 97% of the patients. A few patients, of course, we landed up in trouble, but we were fairly confident of managing this disease. And because in the first wave, we were so confident of using remdesivir, and because we were using it for a long time, this time when the wave started, I think the first challenge that hit us as soon as the wave started was that we were short of remdesivir. Every patient that was hospitalized because of social media, because of WhatsApp and whatnot, wanted remdesivir. Unfortunately, it was not available. Rationing was started. There were local rules, state-wise rules, where in Uttar Pradesh, Delhi, NCR, where I work, it was advised that you give it to patients who had a CT score of more than 7, or patients who were in frank respiratory failure. And, you know, this was kind of an unplanned RCT that we did this time, because in a lot of our patients, even though they had very severe disease or even were on the ventilators, because we did not have access to remdesivir, we did not use it. So it was kind of an unplanned, study that went on. And was remdesivir actually useful? Well, we still do not know. We've not had the time to sit down and, you know, really look back at our data. But I do have a feeling that it does help with fever and the other symptoms. They do go away faster in a patient if remdesivir is used. However, mortality, ICU stay, my guess is as good as yours. So this was the first week of April. The second week of April, when everything was full, the phrase of the month was, no, this cannot be happening. This is not possible. You know, this was a feeling like war. This was, I think, what, you know, this was not possible. And the word of the month was no. I think I have not used the word no more than what I used in the month of second week of April and May. There were no beds. People were calling you left, right, and center for hospital beds, for arranging remdesivir, for giving them oxygen. And the only word that we had was no. I'm sorry, I cannot help you. Second week of April to second week of May, most of the healthcare services were overwhelmed. There was lack of oxygen, lack of hospital beds, horror stories, emotional outbursts from everywhere, people not finding places to, perform the last rites of their loved ones, and, mortality like never before. There was a day wherein, I walked into my ICU, and the whole ICU was replaced by a different population of patients, because whoever were there the previous day had actually succumbed to their illness. So it was mortality like never before. Very rough data. I asked one of my residents to calculate this, very quickly. First wave, 90% of my mortality in my ICU was people who are the age of 65 with at least 2 comorbidities, of which morbid obesity and diabetes was the two most common, comorbidities. This time, the mean age of deaths from my hospital is 42 years. So from 65, 66 years, the mean age of death in this wave has definitely gone down. We've all seen younger patients getting very sick and dying in this wave. Today, the phrase of the month from Know What Is Happening to Us is I don't know. Mortality continues. Although the overall cases are less, we still do not have ICU beds in my hospital as of now. Sicker patients are now coming up from the peripheral parts of Delhi NCR to my hospital. The biggest problem right now, as Dr. Pavan said, is these stuck-up patients, long COVID patients. And I've been talking to some of these attendants now for the past 30 days, 40 days. And the most common phrase that I use all day long these days is, I don't know. When is my patient going to be okay? When is he going to be out of the ICU? When is the oxygen going to go down? We seriously don't know. I don't know. Newer drugs, their efficacy, because in India, as soon as a drug comes out to the market, you have a WhatsApp that's circulated to everyone. So every patient wants bevacizumab, baricitinib, tofacitinib. The Indian DRDO has come up with this new drug, 2DG antifibrotics, and patients keep bogging you with these questions day and night. My answer is, I don't know. I still don't know whether these drugs are useful. In one patient, in every patient, we are using a cocktail of all these drugs, and whether all of them are effective, how effective each of them is, how effective this cocktail is, or whether or not we should be actually using them or not, I don't know. Another question, the hype by media about these various colorful fungi, black fungus, white fungus, yellow fungus, every morning, day in and out, as soon as you open the news, the newspapers, every patient who walks into your OPD, now the situation is so bad. People who are coming in respiratory failure, their families don't want you to start them on steroids because their patient might actually die of the white fungus, yellow fungus, black fungus. Today, there has been a blue fungus which has been reported. Now, I seriously, again, don't know what these colorful fungi are. So the catchphrase of the month is I don't know, and I just hope that by next month we would have answers to a few of these questions at least. So the lessons that we have learned and the way forward is, we are so vulnerable and unprepared, and when I say we, I don't mean India, I mean everyone. Dr. Panchal just said the world's a very small place. We are so vulnerable, we are so unprepared. We seriously don't know what the future has in store for us. India has a unique set of problems, resource limited settings, developing countries. We have a special set of problems to deal with in our country, and hopefully we'll emerge out victorious. Only time would tell. Healthcare definitely needs more attention. We need to focus more attention on healthcare. Our governments need to think more proactively about healthcare, because this is absolutely the need of the hour. We need to now prepare ourselves for wave 3, 4, 5, whatever waves are left behind, whatever the scenes that we have seen in wave 2, I don't think any of us is now mentally prepared or mentally that strong to undergo this trauma again. We need to vaccinate our people proactively, whatever is available. It would be a humble request to everyone who's listening today, even the general population, the general people who are listening on YouTube today, please come forward for vaccination. Please vaccinate yourselves and your families. We definitely need better drugs. We need proactive research into this, and only research and science will save the day. And this is my fantastic team, my ICU COVID in charges, the nursing staff and the ward boys and the IRs who work in our wards and who make our life so wonderful. And I think they're the real backbones of the hospital system that is that is actually saving the patients these days. And hats off to all these people. And I hope that I've set the ball rolling, And in the next lectures, we'll be learning about what is new in COVID management and how do we manage this disease. Thank you so much for your patient hearing.
Thank you very much, Dr. Khanna, for a really very articulate summary of the situation in India. And your final message, I think the vaccination is absolutely key. In the interest of time, I think we're going to do a question and answer session at the end. I think we'll be fielding questions. I'm going to move on and introduce my colleague, Dr. Gerrit Voltman, if Dr. Voltman's able to share his slides. So Dr. Voltman is a consultant respiratory physician and the head of service for respiratory medicine here at University Hospitals of Leicester. He's been a consultant at Glenfield for more than 20 years and has led the department through the COVID pandemic. University Hospitals of Leicester has admitted almost 6,200 confirmed COVID cases, and the hospital's recruited more patients to the key COVID multi-center research studies than any other NHS trust. Dr. Voltman also leads our TB service and our specialist pneumonia intervention service, and is an active member of the NIHR Leicester Biomedical Research Centre and the Leicester TB Research Group, and has published widely. So I'll hand over to Gerrit. Thank you.
Yes, I hope people can see my slides. If I could have a confirmation, please.
I can see your slides, Gerrit. Thank you.
Thank you. And thank you, Rakesh and Hari, for inviting me to speak at this meeting. I don't need to introduce Leicester, I suppose. Rakesh, you've already done that to an extent. Just to remind people that there's no town outside India with a larger Diwali congregation than the Leicester one. This is not a picture that was taken this year. It is not a picture that was taken last year, but it has been taken for many years prior to that, every year. So I'm introducing the Glenfield Respiratory team. Glenfield Hospital is the cardiorespiratory specialist centre that belongs to University Hospitals of Leicester, which has two other sites as well. Two of these sites are acute, and the hospital as an entity manages approximately 250,000 admissions per year, which in UK terms makes us one of the largest, probably one of the largest 3 NHS trusts in the country. We have nearly 30 specialists now, and I hope I haven't forgotten anybody within my team. The team has quite a high proportion of specialists with a background and strong links to the subcontinent. And it was really tangible throughout managing this pandemic that these links to India were very much alive. People were constantly, many of the consultants and many of the juniors in contact with their family at home, and sometimes in very difficult family circumstances, including death in the family. They helped us deal with COVID in the UK, and we're extremely grateful for that. As you know, the Asian contingent in the NHS workforce, which I think is 1.1 million people, the total workforce, is strongly overrepresented in the highly educated group of staff, namely medical staff. 30% of our medical staff are of Asian ethnicity, which obviously is not news to those listening into this session. So Rakesh has already shown the UK summary of the current situation. I will try to focus on the second wave, and will not show much data in relation to the first wave, because most people will be aware of all that. So this is data that was calculated just a couple of days ago, and you can see we're still testing positive people, and the numbers are actually increasing. These are the sorts of red labels that we watch very carefully, but in comparison to the second wave in the middle of January, the numbers really are extremely low, despite far greater testing. So you can see here on the right, in the UK, over the last 7 days, more than 6 million people have been tested, usually with PCR tests. Deaths are right down, and patients admitted with severe disease are also right down. And to see a figure of daily admissions, 123, is really unknown. And this figure continues to drop at present. But obviously, there are signs on the horizon that may change again. And the last presentation felt to me like a sort of a window into the future, which may be nearer than we like. So for those who want very detailed epidemiology based on extensive testing, feel free to go to the data collection sites on gov.uk. I'm going to show data which are in the public domain, so anybody can enter any postcode, maybe, or family members, and it will tell you what the incidence in that particular UK area currently is. You can see we're sort of on the greener side of the colour spectrum. In many areas below 10 per 100,000 average weekly rate. So if we look at both peaks, you can see from these graphs already that we were probably not dealing with 2 peaks and 2 waves, but effectively 3 waves. Only the second and the third wave merged into each other, and that was mainly due to the highly publicized figures relating to patients in hospital. The second wave clearly was more severe in terms of numbers of people admitted in the early part of January than it was in the first wave. 10% of the admitted people ended up in mechanical ventilation beds, shown down here. So 3,000 cases at the peak first wave, more than 4,000 cases in mechanically ventilated beds at the peak of the second wave, which is quite close to capacity, shall we say, normal capacity. It is important to understand the testing infrastructure behind this. And as you can see here in the top graph, that, this graph doesn't actually start in March, it starts in May, because the numbers of people tested prior to May were extremely low. The testing infrastructure was simply not there. The UK government was heavily criticised for having to build that infrastructure, whereas other countries on the continent appeared to have it already in place. Effectively, people were only tested when they came into hospital. So we had the so-called Pillar 1 testing as you came through the door, and that was usually the only test you had. There was no repeat testing, but as you can see, throughout the last 12 to 14 months, testing capacity has been ramped up to enormous levels. So I think the peak here is 1.5 million people tested on a single day, which is, for a country with a population of 60 million, quite a high percentage. The cases reported, this is obviously now very low numbers during the first wave, but that is severely misleading, because this is actually sort of the later part of the first wave. This is severely misleading because there was very limited community testing. So if the right testing had been in place at that point, I would argue that this peak associated with the second and third wave would actually have been of similar size, if not bigger, during the first wave. So towards the end of the first wave, which was sort of in late May 2020, I gave a similar presentation in a different forum and summarized like this. These were the team lessons really from managing the first wave. We were all still a bit shell-shocked at that time point. We had never experienced anything like this in our NHS careers. We were building the ship as we were sailing, and we concluded that really this SARS-CoV-2 virus was a rather nasty entity that was reminiscent of a previous SARS epidemic, but clearly turbocharged by extremely high infectivity, which SARS did not have. We estimated that the mortality for the pulmonary form of this disease was around 30% in our experience. And we felt that nothing was more important for managing this in secondary care than staff safety. Losing medical staff and losing colleagues and nursing staff and auxiliary staff as a result of COVID care is not a good thing to happen. We also concluded that the hospital interventions that were available at the time throughout the first wave really were purely supportive. So there was a relatively limited amount that could be done for patients. Due to this lack of specific therapy, the team felt very strongly right from day one that each and every patient should be offered research, should be entered into one of many national research trials, some of them very large scales. We realized that the available tests and the PCR platforms had clear limitations. There seemed to be negative, there seemed to be poor sensitivity in some patients when the timing of the test was not quite optimal. And many patients were felt to have COVID, even though the tests seemed to say it was not the case. Learning how to judge the patient clinical trajectory we felt was highly complex, and Pranab Haldar will tell you more about the science behind this and what we tried to do to optimize care for individual patients. Of overwhelming importance, and probably number 2 priority for any lead in this situation, was to offer support to staff who were really at the limits of what medical staff can deliver in acute care. And there was a much used phrase in the public domain, is the NHS coping, which was used heavily by members of government. I always felt that this was slightly inappropriate in the context of this disease, as if there was a certain number of patients where it was perfectly acceptable that people would come into hospital and be managed without really specific drugs to deal with this. I felt very strongly that there had been a failure of prevention at the time, and that everything had to be tried to prevent transmission in the community so that the patient does not come into hospital in the first place. At the time, I felt it should be done by contact tracing. There's probably other mechanisms that are perhaps more effective. We didn't have a clear understanding of the mode of transmission, despite extensive literature and graphs like this, which were published from Nature downwards into any medical journal. The importance of aerosol transmission, as we all know, was underestimated, and the WHO came relatively late to this party, but probably still earlier than the UK. And the realization is that airborne transmission is in fact quite important, and therefore proximity between individuals is very important and needs to be minimized. John Bennett, who's part of our team, Professor John Bennett, came up with the SPACES algorithm, which is effectively a way of minimizing staff contact with affected patients by enabling and empowering people to multitask. In other words, if the doctor went into the patient, were there any other tasks that he could deliver on behalf of other team members to reduce their chances of COVID exposure? Leicester has been championed in the UK as the UK's top recruiter to the recovery trial, and Rakesh has already referred to this. The recovery trial came up within 89 days of the first recruit, with the first controlled trial evidence in support of dexamethasone. So just in time really for the second wave, and that was of huge importance, not just for UK patients, but also for patients worldwide, because this is a very cheap drug. Leicester Hospitals, in other words, University Hospitals of Leicester, recruited more than 1,000 patients into the recovery trial. Literally each one of our patients went to one trial or another, and we recruited twice as many patients than the next unit on the list. There was a total of 178 NHS trusts who contributed to this enormous piece of work. So where are we? Well, the WHO website will show that the problem is far from over, but is unevenly spread across the planet. Some areas in lighter shades of brown, some very, very dark still. Overall, the numbers still appear to be increasing, and at the moment, in other words, since the beginning of April, Asia, and in particular Southeast Asia, is very much in the limelight. Your numbers have gone up enormously. We had a similar bulge here, obviously with the second wave in Europe, across Europe. We've managed to suppress that a little bit. And we all know about similar problems in the Americas, be it in Brazil or in the States. So on a smaller scale, but with really quite a lot of value attached, I feel, we get data from the so-called CO-CIN group, that is the COVID-19 Clinical Information Network. All of this in the public domain can be found on gov.uk websites, which essentially describes the typical journey of the patients through NHS healthcare organisations, secondary care environments. The majority of people admitted to a medical ward and not to HDU or ITU, from where they are going to a further ward where care is delivered for a large percentage of these patients using oxygen. A small amount of them receive non-invasive ventilation or even invasive ventilation. And you can see at the end here the outcome associated with each of these bands. So this is pretty much up to date because it includes a relatively small number of patients, 228 who were admitted between 4 weeks ago and 2 weeks ago. But it gives you a snapshot overview what's happening in UK hospitals at the moment and how we're doing in terms of outcome and the typical journey people take. It does tell you that a very large proportion of patients only attends hospital because of the respiratory problems and oxygen deficiency. What is in the same cohort, the hospital medical treatment, I can tell you all cooking with water. Antivirals in the UK did not have many backers, so antivirals are given only to 20% of admitted patients. Antibiotics, on the other hand, perhaps against evidence, are administered in 77% of patients. Antifungals are clearly the exception, and corticosteroids are used only for those with low oxygen saturations. You can see here the various treatment modalities and how these are administered in the UK based on the same cohort in different age bands, and clearly ITU admission and ventilation, yes, in dark blue, tends to be reserved for a slightly younger cohort, but patients up to the age of 90 are in fact admitted to ITU in exceptional cases. High flow oxygen as the standard treatment, therefore much more common in the older age group, as you can imagine, non-invasive ventilation somewhere in between. So ITU, HDU, and down here, invasive ventilation, you can say. So although people go to ITU or HDU, they don't necessarily receive invasive ventilation. The length of stay data is quite interesting because it shows a divergence between those who have an outcome of being alive and those who have an outcome of dying. On the right, the length of stay for those who ultimately die is very similar in the different age groups, but for those who have a positive outcome, those of younger age generally declare their outcome much earlier. So by day 14, the outcome is clear for 88% in this age group, whereas in older age groups, it takes a lot longer to reach the endpoint. So 53% at day 14. So the different age groups really behave very differently. The most scientific and fairest way, it seems, to express mortality in any healthcare system is to look at excess mortality, which is calculated based on average mortality of the previous 5 years. And you can see that the excess mortality was particularly marked in the first wave in the UK and much less so in the second wave. Outcome strictly related to age, as you would imagine, shown in red, 85 plus, shown in purple, 75 to 84 years of age, and here again shown the excess mortality on a weekly plot. So how did we do in our community? Community testing is shown here for Leicester, Leicestershire and Rutland, which is approximately 1.1 million people. This graph doesn't include the first wave, but it shows very clearly that in the community, there were two distinct waves, i.e. the second and the third wave, which were separated through a switch of strains and variants from the original COVID strain to B117, as we know. And this was true in all parts of Leicester and Leicestershire at the moment, and this is right up-to-date data. We are, in fact, very close to the UK incidence for community testing. The UK at the moment stands around 20 per 100,000 per week. There's quite a number of monitoring systems have been installed during the past 12 months. One of the most useful ones really is the so-called NH111 related call system. So this tends to be the first port of call for anybody who has symptoms for any disease, really. You ring NH111 or you go on their website, you describe your symptoms and some advice is given. For COVID-19 related calls, this is quite a sensitive barometer of what's happening in the community, and similar systems, I think, should be recommended to continue after COVID. One extremely useful way of plotting what was happening in different communities is shown here. This was developed by Dr. Foster Intelligence, and it's essentially a plot of the past 8-week daily case rate against the past 7-day daily case rate, which then shows you those areas in the country with accelerating incidence. This is in fact the graph that was plotted in January 2021, right at the peak of, or the explosion, should I say, of B117 in Kent, where this was isolated first. I'm not sure it sort of emerged from Kent, like none of these variants really emerge necessarily exclusively in the country where they're first described or recognized, but this is the so-called Kent variant anyway. And all of these red dots are essentially in the south of the UK. Interestingly, starting off from a very low baseline at that time. So this was not the much quoted sort of extremely high incidence rates that then generates the variants, but it seemed to be exactly the opposite way. So if we move from January 2001 now to February 2001, you can see the problem is now resolving. The same urban areas are now coming down with their acute rate and going back into the sort of issue resolving, returning to normal territory. And the most recent snapshot is in fact this, where both the 8-week rate and the last 7-day rate are identical and very low. However, there are outliers, and these outliers are shown here as Bedford, Blackburn and Bolton more than others. This is not the 7-day rate, but this is the 1-day rate, which you need to calculate by multiplying this by 7 to come up with a weekly rate. So this is entirely due to B1617.2, and this is the current development that we're facing. We're explaining this to people on various channels of communication. This, I think, is a picture from Bolton to make people aware there is a concern in the area. Now, most of these variants, wherever they emerge, and I don't really like attaching country names to them, so you need to remember the numbers. We've all got used to this. Most of these variants spread worldwide. For example, the B117 is now verified in 143 countries. Whether all of this is due to travel or other mechanisms, we don't really know. B1351 started somewhere down there and has been verified in 96 countries. P1 emanated from this, well, was first isolated down here, has already spread to 58 other countries. There are concerns about these variants, and that's why they're called variant of concern rather than variants of interest. And here's the 3 variants which we are very excited about at the moment. And as you can see, these have also spread quite far, quite early on throughout the world. And none of them really stand out. Most of them go to a lot of countries. There is evidence that countries bordering India saw quite alarming rates of increase that had not been seen like this before in such a short period of time. You can see these sharp increases for cases and death in several countries that are adjoining India. You can see here how, based on relatively limited sequencing testing, I suppose, the percentages are very impressive and the change is impressive between individual weeks. So we're talking 6 weeks between the first observation of B16172 and essentially complete domination of the strain landscape in India. Something similar happened in Europe, although the ECDC website does have significant limitations. They say here in very small print, this is based on countries where there's more than 60 weekly sequences, and in many European countries that is simply not the case. In terms of sequencing infrastructure, the UK stands out like a sore thumb, and you can see for this reason UK residents have now been excluded from travel to a number of continental countries. The UK has created this success story, the COG-UK, or COVID-19 Genomics UK Consortium. I would advise you to consult that website and the databases it contains. I have ordered these recognized variants by their frequency of occurrence, and you can see here, in fact, this is already out of date. I think we're now up to almost 8,000 for B1617, which is almost 27% of the UK sequenced variants. There are a number of domains in that variant which have been linked in previous laboratory in vitro research to vaccine escape, but the strongest signal for vaccine escape from the literature appears to come from E484, which is in fact not contained within the B16172, but it is contained in quite a number of other variants. So the important bit to understand is really, if you compare the EU sequencing rates, they are really struggling to hit 5% sequencing, whereas in the UK, if you compare here percentages sequenced between the 26th of April and so this is all the sequencing done up to this 26th of April, and this is the sequencing done since the 26th of April. A much higher proportion of strains is now being sequenced. There's more than 20 million swabs stored at the Sanger Centre in Cambridge awaiting sequencing, and this is quite an impressive performance. And based on this sequencing infrastructure, you can see that the B16172 unfortunately does stand out if you adjust for the different time points by which they emerged, and essentially say, okay, this is a days and specimen date of first reported case. The rate of increase is quite unique for this particular strain, but you can see there seems to be a turning point, and there's always light at the end of the tunnel, I suppose. But for the UK regions with the right fit, i.e. multinomial fit, you can see that really this one in purple stands out. It is the new kid on the block, and we'll have to see how this translates into symptomatic cases admitted to hospital, into respiratory failure. And if I sort of think of the presentation that was just given before me, I'm quite concerned about this, and have to say I agree with modelers in the UK, of which there are many, which predict enormous numbers of hospital admissions, although it does depend on the degree of how much more transmissible this particular variant is. Now, this modeling, how alarming it looks, does assume that complete protection is in place, which clearly is not in place, because 70% of individuals in the UK have not received the second vaccination. I can recommend to read everything you can find by Julian Tung, who's one of our Leicester University Hospital consultant virologists, who's quoted in Nature. He felt that this variant is less likely to pose a problem to vaccination effort than the spread of the other B1617 because of the absence of the 484 mutation. And he also stated that there seems to be no evidence that there's associated increased disease severity with these 617 variants in total. I hope that is true. There's certainly in vitro evidence of quite marked decline and difference in immune response. There's two papers here, the Collier paper and the Greeny paper, both published this year. None of this peer reviewed, obviously, but strong differences suggesting that there is real vaccine escape. So,
Garrett, I'm a little bit over, Garrett, in time. So.
Okay, I'll wrap up. You can see here the B117, how it's spread across the UK. These are websites in the public domain. How rapidly this happens. The same is currently true for the B6172, and you can see this here. This is an important slide which shows you the vaccine efficiency from PHE data, and this, I would argue, is probably the best data we have at the moment, and there's a big step up between first vaccination and second vaccination, conclusion being that the second vaccination is absolutely essential to protect from this particular variant, and every country is advised to accelerate that if they can. do read up on wastewater-based epidemiology as well. There's a strong correlation between virus concentration in wastewater and positive testing, which can be used for outbreak monitoring and is now used in this way in the UK in 500 locations, in fact, 3 or 4 times a week. And this is, again, another early warning system. There's some good news, which is there's no flu this year. So are these Rolls-Royce services? Well, I'm not sure. As I say, this car was built as we drove, and clearly other forms of transport are available. So thank you very much. And I'm sorry I extended my time.
Thanks very much, Gerrit. Thank you. I think we'll move on to our next speaker, who is Pranab Halder, who's going to talk about the medical management of COVID based on evidence-based guidelines. So if Pranab could join us and share his slides. So Pranab Halder is a clinical senior lecturer and honorary consultant physician at Leicester. He's been here since 2011. He's the clinical lead for our rapid access TB service, which provides a centralized referral pathway for the diagnosis and management of patients with suspected TB across Leicestershire. His primary academic interests are in human mycobacterium tuberculosis infection. He's involved in collaborators in Leicester, the Francis Crick Institute and the University of Nottingham. He's also interested in the development of novel biomarkers to enable better characterization of TB infection phenotypes. So I'll hand over to Pranab. We're a little bit over time, but hopefully we'll be able to gather that up with a sort of a smaller Q&A session at the end. So Pranab, are you able to share your screen? Pranab, are you there? I can.
Hi Rakesh, thank you. Yeah, I am there. I'm just trying to share my screen. Just bear with me.
Thanks, Pranab.
Is the right slide showing up?
Yeah, we can see your slides. Over to you, Pranab. Thanks.
Thank you. Okay, well, good afternoon, everyone. And again, once again, thank you, Rakesh and Harry, for inviting me to present today at this seminar, which, as everyone has already said, has got lots of interesting opportunities, I think, to share knowledge and experience. And I was very obviously interested in the talk that Dr. Khanna gave about the experience in India. We're all hearing a lot about what's happening in India through news outlets predominantly, and obviously through relatives. And it's difficult to judge really how well things are being managed. Clearly there is a crisis. And obviously we all keep our fingers crossed that things will improve soon. I've been asked to talk to you about the medical management of COVID-19, which is not an easy task, because reflecting on the evidence that we've obtained over the past 15 months, it's been on an unprecedented scale. And I think what the pandemic has given us really is insight into exactly how much scientific experience, knowledge and infrastructure that's been developed over the past 100, 150 years, how mobilizing that towards one disease, what that can achieve in such a short space of time. And whilst that's been obviously life-saving for our race, for our species, I think it's also brought challenges that we haven't previously recognized. And in particular, what we have witnessed is the performing and presentation of scientific evidence at a scale that, at a very accelerated scale. And these graphs really just to sort of highlight exactly what's happened over that period. So you can see that at the beginning of the pandemic, from the very beginning of the pandemic, there's been an almost exponential increase, both in the number of publications that have come out in the scientific domain, but also a move towards greater publication online in the form of preprints before they've been peer reviewed. And indeed, you know, never before have we seen policy implementation on the basis of scientific evidence that hasn't been peer reviewed. So this is all completely novel. And I thought what was quite interesting was to share exactly what the flavor of the month, if you like, was over the last 12 months. So there was a rapid escalation of papers at the very beginning of the pandemic, speaking about what the projected outcome might be through modeling studies. Over the same period, new papers started to emerge in terms of different diagnostics. And then you can see here with the blue line that there's been a peak in papers relating to public health as vaccination has come online. And more recently, this light blue line refers to papers on mental health, which I guess in many ways reflects the sort of evolving literature now around long COVID. So as we tackle and overcome mortality issues with COVID, we're faced with the long-term prospects and the long-term prognosis associated with this disease. And of course, more will be known about this over the next year or so. And what we've also seen is a very rapid time to publication of papers that are submitted for COVID literature, for COVID-related work, but as a sort of side effect of this, really, anything not related to COVID has seen a delay in publication. And so we talk about the fallout from this pandemic, and we recognize that as a consequence of this, of the virus, there has been a forced neglect of all the other diseases that usually occupy us. And as a TB physician, I'm very aware of the likelihood that there are many, many more people out in the community with active TB at the moment than there would otherwise be. And this is a problem that's shared amongst all clinicians in all specialties. But alongside that, of course, there's the fallout in terms of science that is being neglected. And I guess the rapid increase in knowledge that we've obtained in COVID will be offset by a reduction in or a delay in acquired knowledge in other disease areas. So there is a lot to think about over time. Now, whilst there's been lots of publication, it's been almost impossible to keep up with it. And then in addition to the sort of traditional ways of publication, we've also had, of course, the sharing of information through social media. And Dr. Voltman sort of had a very eloquent way of putting this as a sort of toxic combination of essentially scientific literature coupled with social media hype. And this presents a challenge for everyone in terms of understanding what information is important, what information is not correct, whether the evidence that is being presented to us, particularly if it's in a pre-publication format, is it robust? Is it something I can believe? Or is it confounded by limitations that I'm not equipped to recognize? And then, of course, when it comes to policy implementation, I think we're increasingly recognizing the conflicts that exist between scientific rationale and politics. And then there's the issue of how our thinking evolves over time. And Dr. Voltman spoke about how we perceived COVID-19 at the very beginning of the pandemic. And it was very much all hands on deck and try and understand the disease and try and understand what we can do to protect ourselves and do the best for our patients. But then, of course, over time, we've been exposed to the possibility that of various drugs coming online, which may or may not have benefit And there was a stage, probably in the middle of last year, when the thinking was more around something is better than nothing, and let's give this a try, let's give that a try. We've got to do something. So that was the attitude. But then, of course, as time has gone on, we've now got access to data from randomized control studies, which I'll talk more about in detail here, which give us a much better insight of exactly what is working and what is anecdote. And I think now we have the ability to reflect on risk and benefit more clearly. And I think as clinicians, it is a responsibility on us to ensure that patients are treated in the right way and not by demand or through social media. And I would urge all of us really to sort of take that into account and not to try things that that don't have an evidence base. Irrespective of how desperate the situation is, because we're in a different place to how we were, where we were last year. Last year we had nothing at all, but now we do have effective drugs. So in terms of the evidence that we have, I'm going to speak about the guidance that is broadly aligned between the European Respiratory Society, between the UK NICE, and of course the WHO. And I'll also, through the course of the talk, mention ways in which we've adopted this guidance within our own policies. Now, these guidelines, as I said, have been based more recently on the outputs from several platform-based multi-center, multinational trials going on around the world. And we've already heard about Recovery, which started in the UK but has now expanded out internationally. There's REMAP-CAP, which was set up to look at drug treatments for COVID-19 that was admitted to the intensive care unit. And then there's the program of solidarity trials that have been conducted through the WHO. And then finally, a number of platform-based trials that have originated from the United States, but which are also international in their scope. So I'll refer to these very large, multinational, and therefore hopefully highly representative platform studies, and talk about the results of these trials in order to understand, I think, in order to have the best understanding of what works and what doesn't. Now, I think one of the landmark papers from last year was this one here, which spoke about, in a conceptual way, spoke about the different stages of disease with COVID-19. And in particular, the idea that the disease goes through a viral phase and then may or may not go through a hyperinflammatory phase. And I think this staging proposal, in many ways, sort of underpins the way in which we think about the disease and the way in which we think about treatments, and also presents us with a way of phenotyping the disease. And I think one of the themes of what I'm going to talk about today will be very much along the lines that different treatments are likely to be effective for different phenotypes of the disease. And this is something to bear in mind when, in particular, when assessing patients and thinking about what may or may not work. So the hyperinflammatory phase, as you'll know, is being driven by what's been termed a cytokine storm. So this is essentially a dysregulated immune response to the virus. And the cytokines shown here, and in particular interleukin-6, are the conductors of this storm, and it's dysregulated and it's self-potentiating. So left to its own devices, the inflammatory response gets worse, causes organ damage, multi-organ failure, but is ineffective at clearing the virus. So recognition of this at an early stage and treatments directed towards this have been a sort of a focus of the early drugs that have been tried, because we recognize that this is the sort of primary cause of mortality from COVID-19. Now, as I said, I'm going to speak to you about medical management, and medical management has a very broad scope. We, at the moment, our understanding is very much focused on the treatment of severe disease. So this refers to hospitalized patients and the treatment of life-threatening disease. But as this is understood better, and as we're getting the disease under control, the focus is now moving towards treatments which might be beneficial for preventing infection, preventing transmission, preventing disease progression. And we'll also see, I think, a greater focus on potential treatments for post-COVID syndromes, which are going to appear more and more over the coming months. Vaccination, of course, is the mainstay of prevention. But vaccination alone may be insufficient. And there are a number of adjuvant therapies which are being developed, which show promise, particularly as barrier treatments and potentially as immunomodulators. And I'll talk very briefly about these towards the end. I will focus very much on what we know at the moment in terms of the treatment of hospitalized patients, and particularly with respect to antivirals, with immunosuppressants and antithrombotics. And then Professor Steiner will be speaking to you a bit later about respiratory support. So when talking about COVID severity, the WHO has a very simple and useful classification model. And they classify COVID severity according to oxygen requirements and whether or not you have evidence of cytokine storms. So people who are not requiring oxygen or who require very little oxygen are sort of categorized as non-severe. If people are desaturating to below 90% with high respiratory rate, requiring oxygen to maintain saturations, you fall into the severe category. And technically speaking, these are patients that we predominantly see in hospital. And then finally, we have the patients who are in intensive care who fall into the critical category. And this is a very useful model, and I'll talk a bit more about this as we go through the literature. In the UK, a paper came out last year which developed a mortality score, a predictive mortality score based on fairly simple parameters. So the patient's demography in terms of their age, gender, whether they had comorbidities or not, and also what their early warning scores were, together with a few key blood tests. And using this score, it has a very high reliability in terms of predicting who is and isn't at risk of severe COVID and death. So scores of less than 3 are associated with a mortality rate of around 1%. Scores of between 4 and 8, the intermediate group, have a mortality risk of around 10%. And then as you get above 8, so between 9 and 14, that climbs to a third. And above 14, about 60% of people are going to die. So a very useful score. And actually in our hospital, the score is inputted automatically based on at the time of patient's admission and following their sort of initial blood test. It's computed through an automated algorithm and can be useful to look at. One thing I would say is that this particular mortality score is weighted very much towards age. And what we have seen since vaccination came into being is that people who are admitted in older age groups still have a very high isaric mortality score, but because they've been vaccinated, they're actually protected from developing severe COVID. And so it's probable that the mortality score has less prognostic benefit now than when it was first developed earlier last year. Okay, in terms of measuring severity, these are a number of tests that we also do for patients with more severe and critical COVID. These tests are largely performed in the intensive care unit. From a personal perspective, I'm not sure they add much value because as a clinician, I'm looking at the patient, I'm looking at their oxygen saturations and their oxygen requirements, and I'm basing my clinical judgments on that rather than the results of a few tests. Where some of these tests, and in particular the CRP, I think is helpful to know whether somebody is on the way towards improvement. And I find that helpful in terms of tracking the trajectory of the disease. But in terms of mapping the severity, I'm not sure it adds a huge amount of value. So the first treatment I was going to talk about in a bit more detail was glucocorticoids. And you'll be aware that the recovery study from earlier this year that published in the New England Journal showed that dexamethasone given 6 milligrams a day for 10 days versus usual care had a significant mortality benefit in all comers, and a signal was particularly high in patients who were requiring invasive mechanical ventilation. So people with critical COVID would benefit from dexamethasone, and the estimated benefit was around 30 to 35%. So this was a really welcome outcome, if you like. The benefit was also maintained in people who were requiring oxygen, but was absent in people with less severe disease. Now, the trial used dexamethasone 6 milligrams daily for 10 days, but the WHO also recognized equivalents to that. So prednisolone, methylprednisolone, and hydrocortisone will likely have a similar impact. And the reason I start the sort of discussion around medical management with glucocorticoids is because it is the only group of drugs that we have to date that shows clear prognostic benefit in people who are being mechanically ventilated for COVID-19. And such is the size of that benefit that I think there is a risk when we look at the other trials to make a judgment on the benefit that they may potentially provide, because it's being masked by the benefits of glucocorticoids. And without a doubt, it is the mainstay of treatment for people who are requiring oxygen for COVID-19. Now, obviously the question arises about whether glucocorticoids could be given earlier in the disease to prevent disease progression. And the data, obviously, from the recovery study that I've just shown you suggests that that's unlikely to be useful. So we know that there was no benefit in terms of outcome when given to people who weren't requiring oxygen. There is a risk that we recognize that hyperglycemia actually potentiates viral replication. And of course, we know that corticosteroids themselves will suppress immune responses. So the combination of viral replication together with a suppressed immune response may actually lead to a poorer outcome. And so there is I think the scientific rationale and the evidence that we have would suggest that glucocorticoids shouldn't be given in a systemic way to people who are not requiring oxygen for their COVID in an attempt to prevent them from getting worse. I'm also conscious, and Dr. Khanna mentioned this, of new treatments that are being proposed for treating COVID-19. And one of these, which was the 2-deoxyglucose, is a drug that is thought to interfere with glycolysis that is part of the pathway towards viral replication caused by hyperglycemia. So by blocking this hypoxia-induced factor 1, 2-deoxyglucose may, in theory, actually prevent or reduce viral replication. But I'm not aware of any studies that has demonstrated benefit. But I am aware that it's cheap and it has few side effects. So but it's something that I think needs to be studied in more detail. Now, we can't use systemic glucocorticoids, but inhaled glucocorticoids may have a benefit. So this is a study that is in preprint at the moment using inhaled budesonide. And this shows that inhaled budesonide does lead to an accelerated time to recovery compared with usual care in people who have non-severe COVID, so are not hospitalized with their disease. And that benefit is seen in most groups of patients, so both younger groups and older groups, and also in people who've had disease for less than 7 days and more than 7 days. And potentially is something that could be used to manage COVID-19 in the community. I'm going to move on now to talk about tocilizumab, which is the other drug, the other immunosuppressant, which has shown benefit in people with severe COVID-19. So this is an anti-IL-6, and this shows about a 15% reduction in 28-day mortality compared with usual care. Now, this particular study, usual care included dexamethasone treatment. So I think the power of this study really was that tocilizumab provides additional benefit in people who've got severe COVID. The problem is that tocilizumab doesn't provide benefit in people who are requiring mechanical ventilation, and that's sort of shown here on the forest plot. So it is efficacious in people who are needing oxygen but are not needing ventilatory support. It is also efficacious, borderline so, in people who are being treated with non-invasive ventilation. So I think we have now, with glucocorticoids and tocilizumab, good drugs, effective drugs to try and halt the progression of severe COVID turning into critical COVID, into COVID that's requiring mechanical ventilation through the global immunosuppressive effects of corticosteroids and the blocking of interleukin-6 through tocilizumab. Now, moving on to the antivirals, remdesivir, of course, is the one that has suggested benefit in people with COVID-19. And I wanted to just speak in a bit more detail about the studies with remdesivir. So the primary study was the ACT-1 trial that published in the New England Journal towards the end of last year. And this was a placebo-controlled study that used remdesivir 200 milligrams as a loading dose on day 1, followed by 100 milligrams daily for a total of 10 days in patients who were hospitalized with COVID-19. And their primary outcome was looking at time to recovery, but they also looked at other important outcomes such as disease progression and mortality. One of the things that they did in this study, which I think is very valuable, is that they tried to phenotype their patients. And they phenotyped them in quite a lot of detail using this clinical ordinal scale. And I just want to draw to your attention the key parameters here. So an ordinal scale of 4 is someone who's hospitalized but not requiring oxygen. 5 implies requiring oxygen. 6 is non-invasive ventilation or high flow oxygen. And then 7 is requiring mechanical ventilation. So we've got 4 no oxygen, 7 mechanical ventilation. What the study found was that remdesivir is effective in terms of reducing time to recovery in people who are hospitalized. And the median time to recovery fell from 15 days in people who received placebo to 10 days in people who received the active drug. However, when you break it down, what you find is that the efficacy was limited to people who were requiring low flow oxygen, so those who were clinical ordinal scale 5, and actually the benefit was greatest in people who had developed symptoms within the preceding 10 days. So this goes back to the idea that antiviral treatments are likely to be effective in the viral phase of the disease, which is early on, and the immunosuppressive treatments are likely to be effective when you move into stages 2 and 3 of the disease. So when you're moving into that inflammatory stage. And that's sort of borne out by this study. Now, that would then suggest that antivirals such as remdesivir are probably most beneficial in people before they need to come into hospital, because they're going to have an earlier phase of disease and are likely to be at a stage that doesn't require high flow oxygen. So ideally, I'm guessing that antivirals such as remdesivir may have a role in the management of COVID-19 in the community. The problem with remdesivir, of course, is that it's an intravenous drug. But I am aware that the company, Gilead, are working on oral formulation at the moment. And that's something that may, may come to pass in the next few months. So that may be something to think about in the future. Now, remdesivir in this study was also effective in preventing disease progression, but again, in that group with the clinical ordinal scale of 5. So low flow oxygen support. You can see that disease progression occurred in 8.2% of people who had the drug versus 20% in those who had placebo. And similarly, there was an improvement in mortality, so a rate ratio of 0.28 in people who were in this clinical ordinal scale, but not in the others. So it's a very, very specific group of people in whom remdesivir seems to be working. And this comes back to the point I was making earlier, that drug response is dependent upon the disease phenotype. This has implications because small-scale randomized control trials, even though they're randomized control trials, are not necessarily going to be recruiting patients according to phenotype. They're going to take people at the scale that we're seeing here from a cohort, say, who are hospitalized, but that hospitalized cohort is going to comprise multiple phenotypes of the disease. So when a randomized control trial is done in small scale, those smaller scale studies may mask the benefits of some drugs. And I say this now because there are a number of drugs for which the evidence is not clear. There are a number of drugs which were repurposed, and have now fallen out of favor. But I think a careful look needs to be had at the basis upon which those decisions were made, because I think it's horses for courses. I think different drugs, different phenotypes. And I think in order to write off a drug completely, there needs to be evidence that it isn't working in very large scale trials across multiple phenotypes and looking at the right outcomes. Okay, so moving on to remdesivir in the context of the Solidarity trial. So this is the platform trial performed by the WHO. Here, remdesivir wasn't effective in terms of mortality benefit, which is the primary outcome in this study. However, again, the WHO did a meta-analysis, or the study group from the trial did a meta-analysis looking at all the studies that have been done on remdesivir. And what they did find is that there may well be a benefit in people who have a lower risk of ventilation compared with those who had higher risk of ventilation. So this goes back to that phenotype of disease, and that there may be a benefit there when you take all of the studies which have been done into account. What is clear from the Solidarity trials is that hydroxychloroquine, lopinavir, and interferon are not effective. And I would add that these studies were done in large cohorts, multinational, and done prior to glucocorticoids becoming the standard of care. And that's really important, because you can't make the case here that glucocorticoids are masking the potential beneficial effects of these drugs. So I think there is strong evidence to suggest that these drugs are not effective for these particular outcomes in people with severe COVID. Now, that's not to say that drugs like hydroxychloroquine may not have some benefit in milder disease as an immunomodulator, but the evidence isn't there at the moment. More recently, we've had a study come out that's looked at, so this is the ACT2 study now, which has looked at the combination of baricitinib with remdesivir. So baricitinib is a Janus kinase inhibitor, and Janus kinases are important in modulating the pathways, particularly the interleukin-6 driven pathways of the cytokine storm. So it's got a slightly broader scope of impact and effect on the cytokine storm. And of course, by combining an anti-inflammatory and immunosuppressant such as baricitinib with an antiviral, the study group wanted to see whether actually the addition of that leads to benefits in people with more severe COVID-19, which weren't seen in people who were receiving remdesivir alone in the ACT-1 study. So this was a double-blind randomized placebo-controlled trial, and baricitinib, one of its advantages is it's an oral formulation, so it's given 4 milligrams orally for 2 weeks, together with remdesivir for 10 days versus remdesivir for 10 days on its own. And the primary outcome, again, was time to recovery, and there was a signal in terms of improved time to recovery when the two drugs were used together compared to remdesivir on its own. Now, again, when you break it down by phenotype, so if you'll remember, remdesivir worked best in people with an ordinal score of 5. Here we're seeing, as hypothesized, that the addition of baricitinib is now improving outcome more so in people with a slightly more severe phenotype of disease. So these are the people, the ordinal score of 6, are the ones who are requiring high flow oxygen or were requiring non-invasive ventilatory support. And you can see that the rate ratio there in terms of benefit is much higher, 1.5, compared with the overall benefit of 1.16. Now, a caveat here, of course, is that glucocorticoids weren't used in the standard of care. So this placebo arm doesn't include glucocorticoids, but nor does the therapeutic arm. So we don't know what the additional benefit, if you like, is of using baricitinib with or without remdesivir in the presence of glucocorticoids. And that's obviously a piece of work that's ongoing at the moment. However, baricitinib with remdesivir offers a potential steroid-sparing strategy, if you like, in the management of severe COVID. And this is particularly relevant thinking about the problems that Dr. Khanna highlighted in India, with obviously a very high diabetic contingency, the emergence of mucormycosis and its association with hyperglycemia. I think steroid-sparing strategies that are effective and show efficacy compared with dexamethasone will have a role. Okay, then moving on to anticoagulation. Obviously, we recognize that there is a higher thrombotic risk in people with COVID-19. That's brought on in part by immobility, dehydration, as you would expect with other conditions or the other conditions associated with severe illness. But together with that, the specific effects of the infection in terms of endothelial damage, dysfunction, and the inflammatory response syndrome that's induced, which then leads to release of prothrombotic factors. There's been a number of studies which have demonstrated a potential predictive role for D-dimers to identify people at higher risk of venous thromboembolic events. So those who do experience these events seem to have higher D-dimers at the time of presentation than those who don't. But there is insufficient evidence to use D-dimers as a way of triaging anticoagulation as prophylaxis for thrombotic events. And the BTS guidance, which I show here on the slide, is actually a very useful summary of what we know about anticoagulation in COVID-19. The REMAP-CAP trials looked at both people who were admitted to the intensive care unit and those who had severe COVID but didn't require intensive care, to see what the benefits of therapeutic anticoagulation were compared to prophylactic anticoagulation. And what they've shown is that there is no benefit of giving anticoagulation at a therapeutic dose in people who are critically ill with COVID in the intensive care unit. And it is associated instead with a high risk of bleeding. In contrast, there seems to be a benefit, and this is in preprint at the moment, there seems to be a benefit of therapeutic anticoagulation in severe COVID that's not requiring admission to the intensive care unit. And that benefit is seen in terms of organ support-free days, and also, so this is quite a generic outcome, and not necessarily in terms of prevention of thrombotic events. So therapeutic anticoagulation shows a benefit in both regards, but I think it looks like the benefit is more systemic in its impact than simply in the prevention of thromboses that we treat. However, it does seems to carry a risk of higher frequency of bleeding events, but they didn't reach statistical significance in this trial. But that needs to be taken into account. So the benefits of anticoagulation are systemic, and the impact of prevention of thrombotic events is modest. Our approach here at UHL is to use a high-dose prophylaxis regimen for people with severe COVID and those in the intensive care unit. So the high-dose prophylaxis doses lie in between, if you like, the standard prophylactic doses and the therapeutic doses. So it's an intermediate dosing regimen. And we give this, as I said, to people who are requiring ITU and also those who are requiring non-invasive ventilation, and also those who are admitted to hospital with COVID and a high pre-existing risk of venous thromboembolic disease. So those, for example, who've had previous pulmonary emboli or DVTs. This strategy is based on relatively weak scientific evidence, but I think sort of the rationale really is to improve anticoagulation without increasing bleeding risk to as great an extent. There are some small studies that support this approach, but nothing large scale. And in terms of anticoagulation, when we discharge people who still have evidence of some inflammation, we continue anticoagulation for a period of up to 4 weeks after discharge. The other thing I wanted to talk about very briefly was, of course, vaccine-induced thrombotic thrombocytopenia, which is a very rare complication that has gained a lot of attention post-vaccination. And the risk seems to be associated with the viral vector vaccines, of which AstraZeneca is one, and so is the Indian vaccine. The clinical presentation in these cases is with acute thrombosis that is often within the central nervous system, particularly central venous occlusions that present with headache and seizure, characterized by low platelet count, which has to be less than 150,000 per mil, high D-dimer levels, low fibrinogen levels. Typically, patients who were at higher risk seem to be females under the age of 50, usually within 3 weeks of vaccination. And as I said, the higher risk is higher risk with the viral vector vaccines. In terms of confirming the diagnosis, blood needs to be sent specifically for ELISAs to look for high levels of platelet factor 4, which are associated with the condition, and platelet activating assays to confirm that. Now, the importance of recognizing this condition is really to stop people from using heparin in its treatment, because we know that it's very much like heparin-induced thrombocytopenia, and treatment with heparin will exacerbate the pathology. In terms of treatment, in treating the vaccine-induced thrombocytopenic thromboses, it's essentially with intravenous immunoglobulins, steroids, and to avoid platelet transfusions, because again, that can exacerbate the problem. There's very good guidance from the International Society of Thrombosis and Hemostasis, which you can look at online. And of course, you should speak to your local hematologist. But the important thing is to think about this diagnosis. Now, a few quick words about some other things related to treatment. So antibiotics, we've been hearing a lot about. There is no evidence supporting the use of antibiotics specifically for COVID-19. And the trials have been done in hospitalized patients. No benefit has been shown. And there's no supporting evidence as yet for use in non-severe COVID in the community. We use antibiotics in hospital probably more than we should, as Dr. Walton pointed out, but we try and reserve use to people who've got culture-confirmed bacterial infection following hospital admission with COVID. So this usually a hospital-acquired bacterial infection. If they have a rising CRP with a new fever in the absence of worsening COVID-19 symptoms, or if they have evidence of a bacterial pneumonia, either on chest X-ray or as a result of being of prolonged ventilation. I talk specifically about antibiotics here because this is a prescription of one of my cousins who developed COVID a few weeks ago. And she sent me a list of her prescription at the time. And you can see that this is the standard. Well, those of you from India will be very familiar with this prescription because as far as I can tell, this is a standard prescription given out to people who are COVID positive. And includes a tetracycline, a macrolide, multivitamins, together with montelukast, intravenous dexamethasone in this case, but often it's given in oral format, salbutamol, inhaled budesonide. These are common to all the prescriptions that I have seen, and ivermectin. So this seems to be a standard prescription. And one of the concerns that I have is that with this pandemic, what we are inviting is injudicious use of antibiotics on a population scale. And there is a significant risk of a significant antimicrobial resistance developing as a result of this pandemic, unless we control the use of antibiotics. So this is something that I would urge everyone to think about carefully. Now, very briefly, ivermectin. Rakesh, I'll just be 2 minutes. Ivermectin has been used in India from the very beginning, actually, and has shown promise in small-scale studies. Now, the WHO has basically felt that on the strength of the evidence, particularly from those studies which were felt to have a lower level of bias, the evidence for ivermectin at the moment does not exist as an immunomodulator in terms of improving outcome from COVID-19. And what the WHO says in their guidelines at the moment is that they are not passing judgment on ivermectin. What they do suggest is that ivermectin is used in the context of clinical trials. And I'm aware of several clinical trials which are being set up now, particularly to look at its potential value in people with non-severe COVID-19 to accelerate recovery and to prevent hospital admission. Now, very briefly, just to mention that there are some adjunct therapies of interest, actually, which are in the pipeline, which are likely to be coming out later this year. One of these has a very strong scientific basis to it. So this is the use of linoleic acid as a way of essentially binding to the viral S protein, the spike protein, and preventing its conformational change that would then allow it to attach to the ACE2 receptor. So the idea is a nasal spray with linoleic acid in it would essentially act as a barrier, preventing a viral, if you like, establishment of infection within the nasal mucosa. And in vitro studies have shown very high levels of efficacy in terms of preventing viral replication when used in conjunction with remdesivir in viral culture studies. But that's an exciting prospect, which is under development in clinical trials at the moment. And then you may have already heard about the use of nitric oxide as a way also of preventing the binding of virus to the ACE2 receptors within the nasal epithelium, and also its antiviral properties. Nitric oxide, again, in vitro, kills 99% of virus. So this is already in phase 2 clinical trials at the moment, and we're likely to hear more about this in the near future. And where I think these adjuncts have greatest impact, or will likely have greatest impact, is are as adjuncts to vaccination. And of course, they are immune, by and large, to small mutations within the virus. So just to end, and in summary then, medical treatments for COVID-19 is a rapidly changing landscape that continues to evolve. Treatment efficacy should be evaluated in the context of disease phenotypes. But what we do know is that potent immunosuppressants, glucocorticoids and IL-6 inhibitors, together with respiratory support, have prognostic benefit in terms of reducing mortality in patients who have severe and critical COVID disease. Antiviral therapies may be beneficial, particularly in the earlier stages of disease. effective therapies to prevent disease progression, particularly in people who have non-severe COVID, and to stop them from going into hospital, this is an important gap in knowledge. And while it remains an important gap in knowledge, I think one of the things we must guard against is polypharmacy, because I think the iatrogenic risks arising as a consequence of that are considerable. So thank you all for listening.
Thanks very much, Pranav. That was a superb talk and a great overview of the evidence base and the landscape in COVID management at the moment. So thanks very much. I think it's a really important talk. We're running a little bit over, but I think that was an important talk, and I think we'll move on and do, there's some questions which I'll pose Pranav at the end of the session. So just to move on, we've got Professor Michael Steiner, my colleague, who's going to talk about advanced respiratory support in COVID-19. So Professor Steiner has been involved in the management of COVID patients on our respiratory support units, which manage patients with acute hypoxic respiratory failure outside of the ICU. So Professor Steiner is a professor of respiratory medicine at the University of Leicester and Loughborough University, and is a consultant respiratory physician at Glenfield. His clinical interests include advanced COPD, lung volume reduction therapies, sleep and home ventilation. He's also the editor-in-chief of chronic respiratory disease. So Mick, over to you, thanks.
Thanks, Rakesh, and thanks both to you and Harry for inviting me to talk at this excellent symposium. It's a great pleasure to share our experience with those from colleagues in India, because we've watched with great concern the unfolding events in India with the spread of the virus and the pressure that's being put on health services over there. And I suppose in part because we've all experienced to some degree the same pressures and the same concerns. My first slide, I guess some of which you've seen already. So on the left-hand side, you can see the familiar pattern of virus prevalence over the first and second waves in the UK. In this case, this is data from the Intensive Care National Audit and Research Centre, and on the left shows people in hospital, both on general wards and on intensive care. But I'd like to draw your attention to the graph on the right, which tells us something quite insightful about intensive care occupancy. And you can see how the occupancy from COVID has changed in proportion to the total occupancy from all causes. And you can see in the lines the average occupancy in previous years. So it's quite clear in the UK that at various times, intensive care capacity was really pressured and stretched, and at times additional surge areas in the lighter orange had to be opened up in order to accommodate patients who needed critical care treatment. Now, I'm not a critical care physician, I'm a respiratory physician, so my perspective on how to treat people with respiratory failure will be from a pulmonology perspective, but the management of respiratory failure in COVID-19 is essentially a collaborative one with colleagues in critical care. And so all I'm going to talk about is going to be about how to manage that collaboration and how to manage patients in the right clinical area. So I'm going to cover the aims of treatment and including how to establish a ceiling of care and an escalation plan, which I think is particularly critical. Essentially, certainly in the pulmonary phase of the illness, this is very much a diffusion problem. So the main issue is low oxygenation. There appears to be relatively little increase in mechanical loading of the lungs. Certainly in the pulmonary phase, we don't see an increase in the PCO2. And it might go some way to explaining why many people were observing it, particularly early on in the COVID-19 pandemic, when we were just getting used to the illness, that many patients seem to lack a perception of breathlessness when they became quite profoundly hypoxic, and that there could be quite a rapid decline in oxygenation that needed prompt action, and therefore how we monitor such patients became an issue of quite significant concern. I'm going to go through a little bit about the options for additional support, and that's short of intubation and ventilation, which I'm not going to talk about. As I say, I'm not an intensivist. And I'm principally going to talk about high flow oxygen CPAP and a little bit about awake proning. There's a little technical footnote of terminology here that often what's a term that's used is non-invasive ventilation, but actually what we're talking about is non-invasive respiratory support. We haven't in the UK used positive pressure non-invasive ventilation for COVID-19. As I say, there isn't a rise in PCO2 unless there's underlying lung disease, and there's very little evidence that positive pressure ventilation or non-invasive positive pressure ventilation is helpful. It has been used in some countries, and we do use non-invasive ventilation units sometimes to deliver CPAP, and I'll explain that in a minute. And I'm going to try and cover some practical considerations about how to deliver this treatment, including issues of oxygen conservation, because we became very aware that there was a very severe and worrying shortage of oxygen in India for a time. And actually we had those concerns about oxygen provision ourselves, and there were one or two quite high profile incidents of oxygen supply being compromised in UK hospitals, particularly during the first wave of the pandemic. Now, this algorithm on the left has been produced by a collaboration between the British Thoracic Society and the Intensive Care Society in the UK. And it's essentially an algorithm one could use to manage patients requiring additional oxygen or not in hospital. And just to take you through it, you can see here on the left, if saturations are low, oxygen is provided, and then there is monitoring and decision-making about which ward to go to. And if there is continued hypoxia despite the provision of conventional supplementary oxygen, then there is an option to move the patient to an area where they could receive non-invasive ventilatory support and decide whether the patient might need escalation to critical care. And at this point, there is a decision-making branch about whether the patient should be escalated and whether they will benefit from invasive ventilation. And I think that's a particularly critical decision, because in my view, that very much determines how patients should be treated. And I think this comes back to what we're aiming to achieve with respiratory support and oxygen in people with COVID-19, and principally to remember that the aim of therapy is not to restore normal physiology, but to provide sufficient oxygen for delivery to the tissues. And actually, the targets that we wish to achieve with oxygenation might be different depending on the aims of treatment, and particularly whether the ceiling of care is going to be on our general ward, because the patient is felt to be unsuitable for transfer to critical care and intubation, or whether the patient would be transferred to critical care. And one of the reasons for this is that there is increasing evidence that over-oxygenation does not provide additional benefit in terms of survival, and indeed in some cases might cause harm. And certainly we've seen that in the management of acute myocardial infarction, where patients who were given high flows of oxygen to achieve high saturations did worse than those who were given low flows. And this is a more recent study in critical care showing that an oxygen conservation algorithm in which there was a lower oxygenation target did not result in adverse outcomes. So we've adapted in our hospital, adapted the algorithm on the left to bring the decision-making about the ceiling of care right to the top of the algorithm, and use different targets at times for people who would be managed on the ward. And I think it's perfectly safe to use a target between 88 and 92%, which provides sufficient oxygenation to deliver oxygen to the tissues, but also helps preserve oxygen supplies and ensures that there's no risk, particularly in those who are tiring or have underlying lung disease, of developing hypercapnia. In those who would be escalated to critical care, I think there is a value in higher oxygenation targets, because that provides appropriate early warning should the patient deteriorate and gives teams time to prepare the patient for transfer to intensive care. So these targets and objectives of treatment might differ depending on the category of patient you're treating. Respiratory support in COVID-19, of course, starts with oxygen, but it's worth remembering that oxygen is by no means the only way of palliating breathlessness in those people who have severe disease and who are not likely to survive. And in fact, oxygen in many cases is not the most useful means to provide palliation. And often this is about good nursing care, reassurance, and provision of other pharmacology such as opiates. And I think we often pay insufficient attention to those measures and focus a lot on the saturation. Some oxygen systems, delivery systems, do draw rather heavily on the supply. And an example is the Venturi system, which provides a fixed percentage of oxygen, but does so at the expense of requiring high flows delivered from the oxygen piping. if there is a compromise to oxygen provision, then it's quite helpful to switch to a different delivery mechanism. And remembering that it's not the percentage of oxygen that we deliver to the patient that matters, it's the efficacy of the treatment. So oxygen is a therapy prescribed based on efficacy, in other words, saturation, not on dose. The delivery of additional support, such as high flow oxygen or CPAP, will depend on the availability of the skills and equipment to deliver that treatment and a suitable area to provide that treatment. And a key factor in determining that will be whether you have proper infection control measures in place, because high flow oxygen CPAP are aerosol generating and may put staff at additional risk unless appropriate facilities for isolation and PPE are available. And those factors have been a big consideration in how we organise our care within the hospital. It's worth just remembering that views on the provision of non-invasive respiratory support, such as CPAP and high flow oxygen, outside the ICU for respiratory infection have evolved really rapidly during the course of the pandemic. And the initial guidance that we were given for those patients who might need critical care is that we should not use CPAP or high flow oxygen as a bridge to intubation, that the patient should be rapidly and promptly transferred to critical care so that they could be intubated and treated in that environment. And that guidance has evolved and changed over the course of the last year as we have gathered more experience of using non-invasive respiratory support. And it has been apparent that this type of treatment can be effective and can be effective in preventing the need for critical care in some patients. I say that with the caveat that the evidence base for this practice is still evolving. And as I've said before, an early decision in agreement with the patient and their family, ideally on admission to hospital, on what the ceiling of care should be and whether escalation to ICU is appropriate or will be helpful, is absolutely critical in managing the patient thereafter. So what type of advanced respiratory support do we have available? Well, first of all, CPAP, continuous positive airway pressure, which delivers positive pressure to the respiratory system and does assist with oxygenation through enhancing lung recruitment and assist with washing out dead space. It can be combined with quite high flows of oxygen depending on which equipment system you use, and there are various interfaces, principally mask, CPAP, but also hoods. It does produce aerosols and requires appropriate nursing and practitioner skills to deliver, and needs to be provided in a suitable clinical area, as I've mentioned before. High flow oxygen can be delivered through a mask or through snugly fitting nasal cannula, which you can see on the right. And high flow nasal oxygen has become a much more of a standard of care as we progress through the pandemic. High flow oxygen maximizes oxygen flow and does offer a degree of PEEP in the same way that CPAP does, but at a much lower level. So what's the evidence for these support methodologies? Well, first of all, what is the evidence for using them in acute type 1 respiratory failure prior to the COVID pandemic? Well, CPAP was not in regular use for respiratory failure outside the ICU. And probably the main reason for that was a randomized controlled trial published in JAMA 20 years ago now, which showed no clinical or survival benefit in people receiving CPAP over oxygen alone. And there have been one or two other studies summarized in a systematic review a few years ago, which suggested there might be some short-term improvement in oxygenation indices, but no overall benefit to survival. Having said that, these studies included in the systematic review principally involved post-abdominal surgery, and it's questionable whether they would apply to our current situation. And as I said before, initial guidance during the pandemic cautioned against using CPAP as a bridge to intubation, but we are now very much doing that as we've acquired a knowledge and experience of its use. What about high flow nasal oxygen? The evidence base for this is slightly more promising in that it's been quite widely used, particularly in the Far East. There's relatively little experience in the UK using it outside the ICU. And there is some evidence that it might improve oxygenation and also prevent the need for intubation. However, overall, the summarized evidence, which helpfully has been recently updated in this year, suggests that there is no overall benefit to survival. There are positive benefits on patient comfort, and it does seem to improve oxygenation, at least temporarily. Practice does vary quite a bit internationally, and as I said before, we've had limited UK experience on respiratory wards, but are now acquiring that really quite rapidly. What do we know about non-invasive respiratory support in COVID-19? Well, there have been a number of small clinical series published which suggests that there might be beneficial outcomes for both high-flow nasal oxygen and CPAP, and I've listed some of the references below. I think the main concern with these reports is that they are all small clinical series or observational studies, and the interpretation of data is confounded by variation in severity of the patients before they were recruited, and changing standard therapy as the pandemic has progressed, making it difficult to estimate whether they've had an impact on intubation rates or mortality. So, and Pranab has nicely summarized how our medical care for people with severe COVID-19 has evolved. There's also been quite significant changes in how respiratory care is organized in some hospitals in the UK, and in many cases, respiratory support is provided on respiratory wards, on respiratory support units, but in other hospitals it's provided within the ICU. And of course that will affect the likelihood of the patient going on to be intubated. Nevertheless, the use of non-invasive support has accelerated really quite quickly in the UK, particularly outside the ICU in respiratory support units. And that's how we've been managing respiratory failure in Leicester. We have a very well-equipped respiratory support unit with teams of allied professions and medical staff who are becoming quite skilled in managing this therapy. So overall, I think these therapies do have the potential to reduce intubation rates, but there is also the potential that they might risk delaying the provision of critical care where that's needed. And it's worth remembering that COVID-19 is a systemic illness where there may well be cardiac dysfunction, renal dysfunction, and critical care offers careful monitoring of multiple organ systems, which we simply can't do on respiratory support units because we don't have the ratios of staff to patients that they do on critical care. So I think there is promise from these therapies, but we have to bear in mind what the best interests of the patients are served by in terms of their locus of care. Clearly, to get an answer to whether these therapies are truly effective, we need a randomized controlled trial, and there is one that has completed recruiting. It's called the Recovery RS study, part of the Recovery Stable, and we in Leicester took part in this study, and it was one of the higher recruiters to the trial in the UK. They've recruited over 1,000 patients comparing standard oxygen therapy to high-flow nasal oxygen and CPAP in COVID-19, with intubation mortality as the primary endpoints. Now, I'm very much hoping that will give us some key data on whether these therapies are effective, but it has been quite a difficult study to conduct, particularly in the later phases, as belief in the provision of advanced respiratory support as a means to avoid intubation has solidified, and it's been difficult to randomize patients to standard oxygen therapy without crossover to the other arms of the study. So we'll have to wait and see whether a definitive answer is provided by this trial. I thought I would just briefly mention awake proning. This generated quite a bit of interest during the course of the pandemic because proning is a routine part of nursing care for people on mechanical ventilation for ARDS. And it does seem as if in some patients it does improve oxygenation if the patient is nursed in the prone position. Now, there are some, again, short-term observational studies. You can see on the right here a graph looking at the changes in oxygenation between supine and prone. You can see supine 1, prone 1, and then return to supine, which is SP2. And you've got two groups which were rather arbitrarily defined as responders and non-responders. So I think what we can take from this is that there is some improvement in oxygenation. It probably happens because of better ventilation perfusion matching. It's feasible to do, so most hospitals now have nursing protocols in which the patient is rotated between the prone and the supine position in a way that is manageable for them, and they can maintain eating and other personal care as you need to if you're a conscious patient. I think my take from some of the data is that there's a huge risk of regression to the mean here, in that we do tend to choose to prone patients when their oxygenation is at its worst. And then, of course, it's not a surprise that if you take a measurement sometime later, things have improved, particularly as we know as the course of the pulmonary phase of COVID-19 is really quite bumpy for a few days. So we don't really know if this improves long-term outcomes, but it's a reasonable strategy to undertake, and it's very unlikely to do any great harm. A few practical considerations, and possibly the most important one is the team of staff that you have available to manage non-invasive respiratory support. So on the right, here's our really quite brilliant acute respiratory response team, which was very rapidly put together in the hospital and have very effectively provided respiratory support and also provided monitoring of other patients within the hospital. And they use our electronic observation measurements to keep tabs on COVID patients' saturation respiratory rates, to identify people who might be deteriorating and ensuring that they're transferred to our respiratory support unit if that's needed. A collaborative partnership between respiratory teams in intensive care and palliative care is absolutely mandatory, remembering that this is quite a frightening experience for patients. Non-invasive support can be uncomfortable, particularly CPAP, and if the aim of treatment is palliation, CPAP really can be a detriment to that. High-flow nasal oxygen is really quite a bit better. And as I say, they provide an overview of oxygen requirements for COVID-19 across the hospital. It's critical that you have enough equipment, and we use a variety of units, some driven by oxygen, but also electrically driven NIV units have been used to drive CPAP, and this has the advantage of allowing lower flows of oxygen, which can conserve oxygen because the CPAP is driven electrically rather than through the flow of oxygen. And as has been experienced in India and at times in the UK, oxygen conservation might be an issue. There was an initial concern about storage capacity, and you can see on the right our shiny new oxygen tank, which was installed after the initial wave of the pandemic. But actually, it's turned out that's not the solution entirely to the problem, because there is flow limitation in the piping. And so you can still see a fall off in flow and pressure if there is too much draw on the system. And that can be monitored through telemetry, and we have a process in place to do that within the hospital, and an oxygen group which met every week in order to monitor this whilst the pandemic was at its height. And we developed an action plan to deal with shortage, which involved reducing saturation targets. As I said, I think it's quite safe to reduce saturation targets to between 88 and 92%, selecting lower oxygen consumption treatment modes, such as avoiding Venturi masks and using electrically driven CPAP, and providing concentrators for patients who require low flow rates where we can avoid drawing on the oxygen, the hospital oxygen provision. The ward environment is critically important, and as I said before, it's rarely provided in ICU and non-ICU settings in the UK. In our hospital, it's on non-ICU settings. And there is now a drive to develop respiratory support units in the UK, which is in line with previous recommendations to manage people requiring non-invasive ventilation for conditions such as COPD. The development of respiratory support units may well be enhanced by the COVID pandemic, because there was a great deal of inertia in developing support units in line with those previous recommendations. As I say, respiratory support units have lower staff ratios, and I think there is an issue about monitoring critically ill patients. It's not just about providing respiratory support. There's a concern about infection control, and we had initial concerns about high flow nasal oxygen because you can't provide a sealed unit to prevent expiration of aerosols into the atmosphere. And also concerned about hood CPAP. You can see a picture on the right, and as you can imagine, the inside of that hood for COVID patients just gets absolutely covered with virus. And when you open the port to feed the patient, it'll all fly out. So we try and avoid the hood, but the concerns about high flow nasal oxygen have largely been allayed by studies showing that the aerosol generation is not as high as we'd thought. And you can mitigate the risk of aerosol generation from other sealed non-invasive units, such as masks, by the use of a mask without an exhalation port and venting beyond a viral filter. And you can see a picture of this on the right. So I'm going to finish off just to go back to some data from the intensive care national audit, because this does provides some sobering figures. So on the top there, you can see the mortality rate comparing treatment on critical care in the first wave, i.e. up to the 1st of September, with the second wave. And what's noticeable is that there is an increase in mortality in the second wave. So before 31st of August, the mortality rate on intensive care was around 47%, and it's gone up to 54%. Now, you might wonder, well, how has that happened in the context of the improving care for COVID-19? But I think this tells us much more about how care is provided outside ICU than it does on ICU. So I think we are treating people much more effectively with non-invasive ventilator, respiratory support, and with drug therapy, so that those patients that can be salvaged are salvaged without requiring ICU, and those that do unfortunately need admission to critical care are in the less responsive group of patients and therefore have a poor prognosis. And finally, I think the thing that should occupy us in the UK, and I think it's a worldwide issue, is the graph on the bottom left, which really shows a very marked gradient of COVID-19 in intensive care based on deprivation. So this is using the UK index of multiple deprivation, which is based on a postcode. And it's a really striking finding that more people from deprived areas have COVID and are admitted to intensive care. And this probably reflects the greater prevalence of COVID in people who are socioeconomically deprived. And this is a societal problem that we haven't even started to face. So just to summarize, I think there is the potential for non-invasive respiratory support, such as CPAP and high-flow oxygen, to maintain gas exchange and prevent the need for intubation, although the caveat is that trials are needed. This has become a standard of care, largely, I think, through expediency, and the evidence is following later. That's not the normal way around that we would like to do it, but that's what's happened. The observational data supports its use, but that is just observational data, and we do need trials. CPAP is not great for palliation, and we do really need to think a little bit more carefully about how we palliate people who are not going to survive. High flow nasal oxygen might be better, but does require transfer to a respiratory support unit. And actually, there are other ways of palliating patients. I can't emphasize enough how important having skilled nursing and respiratory practitioner colleagues available to help treat patients. That's absolutely essential. And as I said before, in deploying other means for palliation beyond correcting hypoxia are extremely effective, but often seem to take second place. And finally, if you want to read an account of how the provision of respiratory support has evolved over the course of the year, I wrote an article for The Conversation, which you're welcome to read, but no obligation. And of course, I'd be happy to take questions. Thanks for your attention.
Thanks very much, Mick. That was excellent review of respiratory support outside the ICU and lots of practical tips. I've got some questions, but Mick, we'll sort of do that at the end if that's okay. I'm going to move on to introducing Dr. Caroline Sampson, whose talk is going to be on intensive care management ECMO in COVID-19. So Glenfield's managed just over 100 patients with ECMO since March 2020, so over the last year. So Dr. Sampson is a consultant in anaesthesia, critical care and adult ECMO here at Glenfield, and is the Deputy Director of Adult ECMO and runs the ECMO follow-up clinics. She's involved in retrieving patients with severe acute respiratory failure, both conventionally and using mobile echo, and has specialist interests lie in both of these fields alongside medical education and critical care follow-up. So Caroline, thank you very much for joining us, and I'll hand over to you.
Thank you very much for inviting me. Both of these topics, so intensive care and ECMO management in COVID-19, are probably webinars unto themselves. So for the next sort of 25 minutes, I'm just going to take you on a bit of a very practical whistle-stop tour of what we did in intensive care in Glenfield Hospital in Leicester, what we've learned about these patients. And then I've got a couple of slides on ECMO right at the end, because I appreciate that's quite a niche topic in itself. Oh, there we go. So a lot of these have actually been covered very beautifully by previous talks in this webinar. But just to give you a bit of sort of practical information about our ICU in Glenfield, we're normally a 21-bedded, and we're a bit unusual in the UK in that we're a mixed cardiothoracic, general and ECMO ICU. over the course of the last 15 months, we've actually cared for 287 patients with severe COVID-19, of which 100 were on ECMO. Pretty much as all of the units in the UK, majority male, 70%. Our average age was a little bit younger at 51 compared to almost 60 for most units. And that represents the fact that the ECMO patients were definitely a younger cohort of patients with an average age in the mid-40s. Most of our patients on ICU were ventilated, so it was 80% were invasively ventilated because our fantastic respiratory colleagues were keeping a lot of those receiving CPAP and high flow nasal oxygen, were managing them on the wards for us. Numbers wise, in our first wave, we expanded the critical care unit to 175% capacity. And in the second wave, which went on for a bit longer, where we actually looked after 2/3 of those almost 300 patients, we expanded up to 200% capacity. A lot of this has been covered by Prof. Steiner. So this is really what to do with your patient before you ventilate them. I'm not going to talk about awake proning, apart from the fact that it does work to improve gas exchange, and it certainly often makes the patients feel better. And it's definitely something that can be done on the wards in almost everyone. As opposed to where do you manage these patients who are receiving advanced respiratory care before they get intubated, it very much depends on your setup. We were incredibly fortunate to have respiratory colleagues who could manage these patients on the wards, but certainly in other smaller DGHs in the East Midlands, I know that all of those patients had to be managed on ICU with obviously the bed pressures that the COVID pandemic brought. I think what's most important about this, and that hasn't been sort of covered previously in the talks, is the million-dollar question of when to intubate the patient who is on CPAP on ICU. And I'm afraid I don't have the answer to that. And it is something that we as clinicians have grappled with, more so in the second wave of the pandemic in the UK, because as Prof. Steiner said, in the first wave, many of these patients, when they came, were intubated pretty early on. In the second wave, we managed many more with CPAP initially. Again, to reiterate what he said as well, I think that there is definitely a role for CPAP. I do not think that there is a role for non-invasive ventilation, so for inspiratory as well as expiratory positive pressure. I think that's something that generally in ICU we would do if we're worried that our patients are tiring and their CO2 is rising, for example, in an exacerbation of COPD. I personally think in your COVID patients, if the CO2 is rising or the patient is tiring on CPAP, it is time to ventilate them if they are candidates for ventilation and not to delay. The happy hypoxics that we've already mentioned, so the fact that your patient could be really quite profoundly hypoxic, but not symptomatically breathless or not feeling breathless. And it's very difficult as a clinician from the end of the bed, seeing a patient who's managing on CPAP, maybe at quite high levels, 60 to 70%, who's got a mild tachypnea, so respiratory rate in the mid-20s, who's sitting there giving you the thumbs up, communicating with their family on FaceTime, for you to say, am I going to intubate you at this point? Because we know that with intubation, you have sedation, you have ventilator-associated pneumonia risks, you have delirium risks. That's quite a difficult decision to make. Personally, what we did was we looked at trends. So look very carefully at your patient over those first 5 days of CPAP support. What is the trend in the FiO2? What's the trend in the pressure they're needing? What's their respiratory rate, SATs or PaO2 if you've got an arterial line on in? How often can they have time off for breaks? We would essentially have our patients on CPAP and then rest them on high flow nasal oxygen to allow them to eat. Are those patients still able to mobilise? If you look at all those trends at day 5, I think if they're worsening, seriously consider intubation if your patient is a candidate for intubation. If they're improving, I think it's time to hold your nerve. If they are static, I don't know. I certainly think that we probably intubated some people too early, especially in the first wave, who may have got better with CPAP only. And I think maybe our pendulum swung too far in the second wave, and we maybe held off intubation too long for some of these patients and potentially increased patient-initiated lung injury. So we've intubated the patient, we've made that decision. What's the next management? What do we do practically in Glenfield? Proning was the mainstay of our treatment. It's very effective, particularly in the early stages of COVID pneumonitis. We actually had proning teams, so we were using colleagues from around the hospital who were maybe not so busy, such as our orthopaedic surgical colleagues, who actually came and did the physical turning of the patient with either an anaesthetist or an intensivist at the head end. And actually the teams approach was something that we used quite a lot in ICU when we were that busy. Our anaesthetist intubated and put lines in, our orthopaedic surgeons came and turned the patients. We had sort of other teams that were looking after all these special things. What's really important, I think, if you're going to prone the patients, have a standard operating procedure, use common language, get everyone involved, practice. It's a whole team effort. In Glenfield, we used a trigger of 60% oxygen from the ventilator to prone the patients if you needed more than 60% to achieve a PaO2 of 7.5 kilopascals, or that's 57 millimeters of mercury. And that's worth pointing out that actually we relaxed our oxygenation targets in these patients. A lot of patients seem to sit with PO2s in the 7s, so 7.5 to 8, that were quite happy with normal lactate, and sort of other organs were fine. And I think that it's always the way, isn't it? Don't aim for normality, but certainly in COVID, actually, we relaxed our saturation targets as well, certainly over 88, and some of them sat in their mid-80s and seemed to tolerate that quite well. Practical stuff for proning: turn when you have the manpower to do that safely. In general, in Glenfield, that meant we turn them on the afternoon ward round, somewhere between 4 and 6 p.m. We aim to leave the patients proned for 16 hours and then turn them back in the morning, again, at about ward round time. And that was really a case of having more hands on deck at that time. If your patient is due to be turned back supine at 3 o'clock in the morning, leave them on their front for 20 hours, leave them for longer and turn them back within daylight hours, because a lot of these patients did deteriorate from a gas exchange point of view when turned back supine. That's the other practical advice that I would give. If you have a patient who is significantly hypoxic and is responding to proning, anticipate that when you turn them back supine, they will not tolerate being in that position for long. So if you've got to do anything, chest x-rays, echoes, change lines, anticipate that you will have a short window and get everything ready before you turn them back supine. We carried on proning people unless they stopped responding or they started to get better. So they were maintaining PaO2s of 7.5 kilopascals and above on 60% or less from the ventilator in supine position. My threshold for response, I like to see you be able to turn down the oxygenation on the ventilator by at least 15 to 20% to achieve that PaO2. There are some patients actually who have less of a response with their oxygenation, but in prone position, they're obviously, they've got better compliance, which is probably to do with recruiting atelectatic lung. And there's also a small group of patients who probably had benefits with their right ventricular failure in prone position. So if your patient didn't particularly improve their oxygenation in prone position, but your compliance is much better, so you can lung protectively ventilate them, or that they're needing far less cardiovascular support in prone position, we would carry on doing that. There are pitfalls. I think that a lot of these are avoidable if you know about them. The big one is pressure sores, particularly on patients' faces. Be really careful about positioning of NG tubes. Just use tube ties if you're going to prone your patients. The anchor fix tube supports where you stick them onto the patient's faces and there's hard plastic holding their ET tube in place are brilliant when your patient is supine, but when they are proned, there's hard plastic, and we've seen some quite nasty pressure sores from those over the years. Endobronchial intubation, obviously, if you turn your patient either prone or supine and they fall in a heap, think, has my tube gone down the right main bronchus? Has it kinked? Have I mobilized some secretions and in the actual process of turning that we need to clear? Feeding can be an issue in the prone position. To be honest, if we had someone who was absorbing their NG feed nicely supine, we would obviously stop the feed to turn them, but when they were turned into the prone position and settled in the prone position, we would restart the feed at the same level, but we would do an early gastric residual volume, and we'd actually reduce the gastric residual volume that we'd accept for patients in the prone position down from 400 mils to 200 mils. Spontaneously breathing patients, so those who were on a spontaneous breathing mode on the ventilator, either CPAP, ASB, or airway pressure release ventilation, you can turn them prone, and we certainly did do that in Glenfield. Again, you would want a reasonably experienced team to do that. But we found that a lot of these patients, especially those who were later on in the course of their disease, and actually CO2 clearance was becoming a problem as compliance worsened. If you paralyze these patients to put them on a mandatory mode of ventilation to turn them prone, they deteriorated significantly. And we did have quite a few number of patients that we proned on spontaneous breathing mode, so it is possible. There's a few rarer things to watch out for. If you turn your patient prone, their lactate climbs quite quickly over the first couple of hours. Have a think, is this hepatic perfusion, and turn them back supine to see if it improves. What about other ventilatory modes and adjuncts? Obviously, all patients, lung protective ventilation, we found that a lot of them, especially early in the course of their COVID-19 pneumonitis run, were very compliant, and actually we used slightly higher tidal volumes, so between 6 and 8, but more to the 7 to 8 range rather than 6, which they tolerated quite well with keeping the plateau pressures safe. We did use PEEP, and we used PEEP incremental trials. We rarely go above 15 of PEEP, to be honest, in Glenfield, and most of these patients seem to have an ideal PEEP of somewhere between 10 and 12. APRV, I don't know if that is a mode that you're using in your ICUs. Again, there is no evidence about whether this improves mortality, certainly in COVID patients, or whether it could potentially harm them, but it is a mode that we used quite successfully in some of our patients and improved their gas exchange. It's really important, though, not to introduce new stuff in the middle of a pandemic when you're operating at 200% capacity. So only think about alternative ventilatory modes if all the team are happy to use it. Because I think what you risk is somebody switching between the modes that they are familiar with. So you get a different ventilatory mode used for patients on different days by clinician decision rather than by what that patient needs. And I think it can be confusing, especially for maybe more junior nursing staff and even nursing staff who are not normally ICU nurses who've come to help from other areas of the hospital. So consider if all the team are happy to use it, have a really simple weaning protocol. And I will share mine with you on the next slide, which you're very welcome to use. It's the one we used in Glenfield. I think it's really useful for the patients who you cannot prone for some reason, or the ones who've stopped responding to proning. And if you are going to be switching between modes, remember with APRV, your mean airway pressure is much higher than with, for example, a BiPAP mode. And when you are changing back to a mandatory mode or even a spontaneous ventilatory mode, think about using higher PEEP in those patients. We didn't use the oscillator, to be honest. We haven't really used it since Oscar and Oscillate in 2013, and we certainly didn't use that in COVID. And I didn't hear of any local units who were using it successfully. We are a cardiac unit. We do use inhaled nitric oxide normally. We did use that in our COVID patients, particularly in the ones with PEs who had some right ventricular dysfunction. Again, there is no evidence that it improves mortality, but it certainly bought a bit of time potentially for those patients' underlying disease process to reverse or resolve. And if you don't have inhaled nitric oxide, an alternative might be nebulized prostacyclin or even things like nebulized milrinone. That's just a brief sort of our APRV on 2 slides, how to wean it for the sort of novice ICU clinicians and nurses. Air leaks, big problem with COVID. We saw a lot of air leaks and it was everywhere, subcut emphysema, lots of pneumomediastinum, a fair number of pneumothoraces. I actually think that pneumomediastinum is much more common in this illness than we first realised. And I'll show you an X-ray next, but I think if you look back at the admission chest X-ray, so before any positive pressure ventilation, you can actually see it in the patients who end up on ICU quite commonly. I think it is a marker of more severe disease. And interestingly, it's something that colleagues saw in SARS. So a paper from Hong Kong published in 2003 noticed a 12% of spontaneous pneumomediastinum, so again on admission chest X-rays, before any positive pressure ventilation was given, either CPAP or ventilation. And that compares to a sort of average and ARDS of 7.5%. So it is much higher with SARS, and I think it's much higher with COVID. It does portend a worse disease, and I think it does portend a poorer prognosis. And I think that's especially the case for pneumothoraces. And if we look at our ECMO data, only in all of our ECMO patients who either came with a pneumothorax or developed a pneumothorax through their treatment with very lung protective ventilation, because we were using the ECMO circuit to ensure that, actually, whilst we had 50 to 60% survival in this cohort, if they had a pneumothorax, that was under a third. It's really important whenever you see air in places you don't expect it to rule out things like tracheal, airway or esophageal injury. And these patients have really friable lungs. I'll show you an example of this later on. But I think on the main, actually, it's to do with the disease process, the COVID pneumonitis, diffuse alveolar damage causing air leak, and that tracking down the path of least resistance into the mediastinum, often down the bronchosvascular tracts. How to manage it? Promptly drain any pneumothoraces, but any other air, watchful waiting. We wouldn't drain air anywhere else. And this is just a sort of, let me get my pointer on here. So this is just to sort of have a look at your chest x-rays from admission. This obviously is a patient who's a bit further down the line, who's on ECMO, who's got a trachea, and you'll notice they've actually got a right-sided chest drain. But I think it beautifully picks out, it demonstrates that this patient had a pneumomediastinum. You can see the aortic knuckle and the cardiac outline, particularly the left cardiac border, really sort of almost outlined with air. Medications, again, this has been covered fantastically by one of my colleagues already in the seminar, so I'm not going to dwell too much on this, but practically what did we do in ICU? Antimicrobials, stewardship is really important. We do not treat viruses with antibiotics. However, missing antibiotic treatment in those with superadded bacterial infection is obviously also detrimental to the patients. I think it is really important to be very sensible with your antibiotics. We used procalcitonin really to sort of try and de-escalate antibiotics as early as possible, because CRP obviously can be up when they're just inflamed from the viral pneumonitis. Really important to do surveillance. We did weekly sort of non-directed bronchoalveolar lavage or ET aspirates, which we sent off for MCNS, and galactomannan for aspergillosis, because we had quite a number of secondary aspergillus. And antifungals, particularly for the patients that are later on in the course of their ICU admission. Like I say, we saw quite a lot of aspergillus, and we saw quite a lot of candidas, not just albicans, but other species, including ones that some of us have never heard of before. We didn't see the mucormycoses, I don't think at all in the UK, certainly none sort of locally. And that it sounds like it's been a real problem in India. We've been over anticoagulation. We use the intermediate dosing. So essentially we used our normal weight-based dosing, which we doubled for our COVID patients. And that seemed to sort of play out when the evidence said that therapeutic anticoagulation in these patients may increase mortality in the ICU. Steroids. So again, we've talked about this, 10 days dexamethasone at 6 milligrams or 6.6 milligrams once a day was the standard of care. We actually empirically doubled that in our sicker patients. So in all the patients who we had on ECMO and in our patients who were ill enough to need proning, so needing more than 60% from the ventilator to get that PaO2 of 7.5, we empirically doubled it. It was the feeling that all of the severe acute respiratory failure, so all the ECMO centres, of which there's 6 in the UK, was that the more unwell patients probably did respond to higher steroid dosing. And a lot of my colleagues in the other centres were actually suggesting the sort of DEXA ARDS level of dexamethasone, so 5 days of 20 milligrams once a day, followed by 5 days of 10 milligrams once a day. But we just doubled it. We also had a lot of patients with high BMI. Actually, in our second wave in Glenfield, 50% of the patients had a BMI of 30 to 40. So we were empirically using bigger doses in these bigger patients. Late steroids, again, nothing in the evidence about this, but certainly we did, it's always been our practice in later stage ARDS when we've got signs of early fibrosis to think about whether steroids, to have a trial of steroids. With some that seem to respond beautifully, and whether actually that just unmasks people who'd had a steroid responsive condition underneath, I'm not sure. We did try it in our COVID patients, certainly in the ones who had late stage disease, signs of early fibrosis, so traction bronchiectasis or honeycombing on their CTs. And we generally used a methylpred bolus, so 500 milligrams once a day for 3 days for our smaller patients and 1 gram for the bigger patients, followed by a pred taper. But we actually had a shortage of methylpred at one point in the UK, and we were using essentially a Majuri dose with dexamethasone instead. Again, some people seem to respond to it. again, there is no evidence in this area. We were using tocilizumab, we were using remdesivir. Most of these were started prior to patients coming to ICU, and actually particularly with the toci, you could only give that within the first 24 hours of ventilation. Fluid management, I think in the first wave, we probably did our normal ARDS, dry them out, you know, sacrifice the kidneys to save the lungs. And actually we had much higher number needing renal replacement therapy, 25% of all ICU patients in the first wave. And that had fallen to 10 to 15. And I think we realized these patients came really quite dehydrated, were pretty pyrexial, so insensible losses were high and were often quite tachypneic, especially when they were being managed on their sort of CPAP run. So we had much more judicious use of fluids in the second wave and actually saw far less unhappy kidneys. Everything else we gave only as part of trials. So we did not use any other treatment apart from our sort of basic, you know, our insulin, our anticoagulation, our antimicrobials. Everything else was given as part of trials. Complications, particularly pertinent to COVID-19 that we saw in the ICU, we've talked about air leaks. We had lots of superadded infections and quite a lot of these were multi-drug resistant. Lots of VAPs, lots of line infections, whether this is the length of time that these patients spent on the ICU, whether this is the fact that actually quite a lot of them were quite profoundly immunocompromised, both from the steroids, from the severity of critical illness, and then from the sort of secondary immunosuppressions we were doing. We saw a lot of Klebsiella, a lot of resistant Pseudomonas. Later on in the course, we saw more Stenotrophomonas, and we saw some Staph aureus and quite a lot of enterococcal line infections. And this is why antibiotic stewardship early on in the course of their illness is really important. So you're not selecting these multi-drug resistant bugs later on. These patients bled, but they also clotted. We saw this particularly with the ECMO patients, but also with the ICU patients. And actually the anticoagulation is really difficult. And this is, I'm sure, to do with the COVID sort of endotheliopathy that we saw. We had a number of heparin-induced thrombocytopenia, mainly in our ECMO patients who we anticoagulate with unfractionated heparin, and had to change them to argatroban. But we also saw it in our normal ICU cohort who were generally being treated with low molecular weight heparin. These patients do have friable lungs, and I will show you, we had 4 cases of patients where NG tubes went through the lung parenchyma. And this is just a chest x-ray of one of the patients. And you can see this is a NG tube that didn't have a guide wire in, was put in by a senior anaesthetic registrar, had no resistance on going in, whereas obviously normally when it goes into the lungs of a ventilated patient, you feel that resistance, and it couldn't get an NG aspirate. And when we did the routine chest x-ray before giving anything down that NG, you can see it's not only gone down the right main bronchus, but it's gone through the substance of the lung, and it's actually causing pneumothorax on this side. We had 4 cases like this, one in our ECMO patient from a surrounding hospital, but just in the ICU. In Leicester, and we had heard more cases throughout the country. So this is not normal. Normal airways would not be punctured by a simple plastic tube, so watch out for this. Lots of patients with edematous upper airways. We had quite a lot of post-extubation stridor, and there were even case reports from across the country of people having to go to the operating theatres, the NT surgeons, to surgically remove some endotracheal tubes. And that just means one of the really important things if you're thinking of going for primary extubation and not a tracheostomy is to check that they've got a good cuff leak before you take that tube out. Lots of delirium. Again, is that the length of time they're in ICU? Is that something with COVID themselves? Is that because we were all wearing PPE and their relatives weren't able to visit as much as possible? I don't know. And we did see, as I'm sure you will all be very well versed with, prolonged ICU, prolonged hospitals and rehab stays. I'm going to move on because we are slightly running out of time, and I do want to talk very quickly about ECMO. So UK ECMO is centred in 6 centres, of which Glenfield is one. We divide the country up normally between ourselves. You'll see that from the picture on the right, with a centre in Scotland who look after the Scottish patients. Very early on in the pandemic, we realised that we were going to get a lot of referrals and this was going to be busy in ECMO. We went to an online central referral process. We updated our referral and acceptance criteria for ECMO. And to give you an idea of numbers, so of all of the UK ventilated adults, which is about 14,000, 20%, so just over 1 in 5 were referred to ECMO, and we took 4%. On average, between the 6 centres, we look after about 280 adults a year. in the last 15 months, or in the last year, that was 678. And we peaked at 86 on VV ECMO at one time, whereas previously that had been 37 and normal operating it's 21. Bit about these patients expect longer runs. Our normal ECMO run is 7 to 10 days. In the first wave, survivors had a 20-day average. In the second wave, that was almost 30 days. And you can see some patients were on for over 120 days, but did successfully come off ECMO. Lots of increased bleeding, clotting complications, like I say, heparin-induced thrombocytopenia. We stopped doing thoracotomies for bleeding around lungs because we had 3 patients and all 3 of them died. That they really are friable lungs if you're thinking of operating on them, almost like butter. Overall in the UK, 72% ICU survivor in the first wave out of just over 200 patients. That had fallen by the second wave. I think in the second wave, we were all seeing at least partially steroid resistant patients, so they had more severe disease. So that was down to 66%, and slightly less of them obviously have got out of ICU. Now following these patients up, they are frailer at 6 months. So they are, which is probably because of the prolonged time that they've spent. And I know we're going to talk about lung transplants, yes, but we haven't done any lung transplants in the UK from ECMO to date. This is just very quickly, sorry, that's not come across very well. We changed our ECMO referral criteria. We use something called the RESP score, and that essentially looks at lots of different measures, but it looks at age, the length of time someone's been ventilated, the cause of their ventilation, and then a few other things that are known to be associated with a poor prognosis. And we cut off at a RESP score of 3 or less. That didn't necessarily mean that if you'd been on a ventilator for more than 7 days, you wouldn't get accepted for ECMO, but it meant that at least 2 centres had to MDT and agree to put patients who've either had a RESP score of 3 or less, or who'd been ventilated for more than 7 days. And we've very much worked as a network. So really quickly, it's 3 o'clock in the morning, your patient is deteriorating. This is my go-to steps to look at them. So you've got a patient who's ventilated. So the first thing is rule out the easily reversible causes. Has your ET gone into the right main bronchus? Is it blocked with secretions? Is your filter waterlogged, particularly if you're using nebulized prostacyclin? Has the patient blown a pneumothorax that needs draining? Are there secretions? Is there sign of new infection? Do some cultures, think about a line change, add or change your antibiotics, think about an antifungal if it's later on in the disease. Prone the patients at that point. Consider muscle relaxation. Fluid management difficult, the Goldilocks, not too much, not too little. But essentially, if you've got a patient that's a little bit later on in their stay and they are 7 litres positive on paper, diarise them at that stage, you might improve their deterioration. Think about cooling your patients to normothermia, reduce that metabolic demand. Think about more steroids. Like I said, we did use some later on in the course of the disease, particularly when compliance was falling. There were signs of early sort of potentially fibrotic change on their CT scans, and they didn't seem to have, if their PCT was low, they didn't seem to have superadded infection at that time. And then think about your investigations. I'm going to stop there, and I will happily take any questions at the end.
Thank you very much, Caroline. I learned quite a lot from that talk, and I'm sure people will be referring back to it later. So we'll do a couple of questions at the end. So thanks very much. I'm going to move on. Thanks. So I'm going to introduce Dr. Srinivas Rajagopala. He's the director of the Medical Transplantation and Transplant and Critical Care Unit, and co-director of the Lung Failure Unit at Yashoda Hospitals in Secunderabad, and is in a lung transplant fellowship in Toronto. He's also been an awardee of the NHLBI Health Research Methodology and winner of the ASCO IDEA Award in Thoracic Oncology in 2017, has written 70 international papers and 12 book chapters, and he's going to be talking about lung transplant in ECMO. So Dr. Rajagopalan, thank you very much.
Thanks for the introduction, Dr. Panchal. I hope my screen is now visible. And
yeah, we can.
That was a wonderful talk and it's a hard act to follow. But my talk kind of nicely continues from that point. So I have a similar patient that was being discussed just now. So 48-year-old teacher with no comorbidity except a BMI of 28 prior to the current illness. She was admitted with severe COVID on 8th day of her illness. She was very quickly intubated for severe hypoxemia, really profound kind of hypoxemia. And despite proning, we were not able to maintain. There's significant respiratory acidosis and hypoxemia. And then after the second cycle of proning, her oxygenation continued to kind of worsen. And then she was on all the usual kind of therapies that we were talking about here. Now, so she was initiated on VV ECMO, but standard like IJV and right femoral on day 3. She had good flows, and her oxygenation and gases improved. So initially, for the first 2 weeks, she was managed with a lung rest strategy, sedated heavily. Briefly, for about 72 hours, she was paralyzed as well. She had tracheostomy by day 7, and there continued to be no clinical, in the sense, no significant volumes generated on the ventilator at kind of the rest strategy, and radiologically, she continued to be completely flooded. After the end of the second week, we kind of stopped the sedation, made her awake, mobilized her to a chair with active physiotherapy, and let her do intermittent tract masking, which she did tolerate. And by the end of the third week, there was continued to have significant extensive air bronchograms with no resolution on the X-ray and clinically as well. So she always remained in a single organ failure. Her course was actually not punctuated by any significant infection except one episode of E. coli bacteremia, which we did change the circuit by day 31. So these are kind of the admission X-ray. This is actually day 3 of illness, day 8 of illness, day 2 days outside hospital, and day 3 in this hospital. And then this is a week later, X-rays, obviously with the cannula in, and then showing extensive alveolar consolidation bilaterally with new mediastinum. So this patient was at that point, 4th week, referred to us for possibility of lung transplantation. So in this kind of background, we'll talk about what is the rationale about lung transplant, and if there is, what are the gray areas there, and what are the concerns about this, and then go through some data about this. So all of us are very kind of very aware of the traditional description of ARDS, wherein there's an exudative acute phase, which typically lasts for less than 4 to 7 days, in which the alveoli are actually flooded with inflammation, neutrophils, and there's intense coagulation and fibrinolytic pathway activation. Initially, it was believed that this was subsequently followed by a proliferative phase and a fibrotic phase. Subsequent research kind of suggested now that this kind of happens by the site, and then there is evidence that fibrotic activation actually starts by 72 hours in several of these patients. So the traditional model of ARDS kind of suggests that most patients should kind of improve by the end of the 3rd week. And so there is actually not much data on really in the modern era with current ECLS therapy about the natural history of ARDS. In fact, if you look at a fairly recent paper, this is 2018, looked at data from previous trials though, about what exactly is persistent ARDS. This problem is mainly because of, especially in the US, where a lot of fluid therapy kind of complicates ARDS definitions, with people looking at fulfilling criteria for ARDS because they have received significantly more fluid just prior to the diagnosis of ARDS, and then they quickly clear the alveolar edema or the therapy. But there is, of course, a true set of patients who have profound hypoxemia, poor lung compliance, who have the traditional ARDS. So this is kind of this group which published their looked at the data from previous seminal trials of ARDS, and then defined this cohort of what is persistent ARDS, meaning like this subgroup of patients actually had a persistent PF ratio of less than 100 for more than 48 hours from diagnosis, which this typical in this this cohort of severe hypoxemic patients were actually 1/5 of the total cohort of these patients. And then you can see that like these patients had more pulmonary ARDS, they had more multi-organ dysfunction, and then they had more profound ventilatory abnormalities. This thing. But what we don't know is that what is the natural history subsequent to this? Like what is the proportion of patients that kind of remain ventilator dependent or remain go on to develop ECLS, and what is the duration of ECLS, and what would be the kind of the outlier of distribution of ECLS. For example, as we heard from the previous talk, there are patients who, most patients would, would definitely tend to get better by 30 days. But there are reports that of patients that we hear on and off, when we talk with colleagues, of patients being ECMO dependent for months together, and then some of them subsequently decannulated, but of course several of them lost on the way. So what would be the ideal natural history is confounded by the fact of the traditional model of ARDS being binary in the terms of resolution versus death. And then there are very few prognostic models for recovery in ARDS. For example, we have similar models in other organ systems, for example, the liver, for example. And then most outcomes of ARDS recovery have actually looked at a 28-day mortality outcome rather than the other maybe equally relevant outcomes. Data on survivors have actually been focused on survivors of ARDS and then focused on recovery or persistent abnormalities. So we don't have really data on what would be the kind of outlier data for ventilatory support or otherwise. So lung transplant for ARDS, however, was described has been described worldwide, and several centers, including Toronto, where I work, there was a small cohort of patients which had undergone transplant for ARDS, meaning that especially these were patients where those first swine flu or epidemic or a non-epidemic local kind of flu. So it is not that it was not unknown. However, it's not a very kind of a typical indication, and it's not in the, for example, in the ISHLT consensus document. And COVID, of course, ARDS has definite peculiarities, all of which we've heard about already. In other organ systems, there is kind of a clear demarcation about when an acute injury evolves into kind of a chronic injury. And then, of course, most of this data typically comes from the kidney field. So based on this, we would, there's a good rationale to use 3 months as a cutoff for defining chronic respiratory failure after an acute injury persists and then beyond 3 months. The cutoff of 28 days is actually based on the traditional resolution of ARDS model by adding a median of another 7 days to the additional 21 days. So so why not lung transplant if you for ARDS or for these patients who have an acute one-shot damage? So the main problem here is that these are not waitlisted patients. These are not patients with chronic lung disease who have actually been have undergone good counseling, good evaluation for lung transplant, and then gone through this process, psychologically made up their mind about this process, had time to interact with the system. And these were patients who acutely came in unwell for another illness, did not really come thinking that they needed a transplant. And then these patients have been prioritized over patients who have otherwise been waitlisted for the chronic lung disease, and that, as can be understood, has immense ethical issues, concerns there. And the concerns are amplified, especially when patients who are sedated and paralyzed and not engaging in decision-making are considered, which should not be. And then there is always a concern that even if these patients are engaged and then they are kind of active in physiotherapy, but not really active in the sense that they're not able to walk, but able to sit in bed or engage in some minimal physical activity, the outcomes would be inferior, and that has an impact on organ utilization, especially where this is a limited resource and there are a limited number of transplants occurring per year lung-wise. So what really would be an appropriate time for lung transplant? So the concern here is that there is not really good data. So when would you think it's too late, or when is it too early? So to resolve this, we can look at data that is published for lung transplantation in COVID. So this is a PubMed search. We retrieved around 947 articles about ARDS, and then this kind of revealed essentially several case reports and two basically a case series. One is a registry review, another is a case series essentially. So if from this, there are some interesting points that arise from this kind of published literature. One is that several of these reports are from really high volume center like Hanover and Cleveland, for example, and Sydney. But then there are other high volume centers, including Toronto, which have actually not published their literature, meaning that there is significant under publication bias in what is actually available in the literature. The other thing that really strikes immediately, as is clearly evident, is these patients are quite young as opposed to the traditional lung transplant population, which is now predominantly, one could say geriatric, except the CF patients and IPH patients. So these patients are quite young and often don't have any significant comorbidity, which is the rationale for, really prioritizing them for transplant. The other thing that is also quite evident is that this is not a frequent occurrence. For example, St. Vincent, which is a fairly large volume transplant center, over a period of 5 years, considered only 7 of these patients for transplant, and actually only 2 of them underwent transplant. So it's not a very fairly common. This is not a common occurrence, especially before COVID. Now, the other thing that is actually striking is that the timing for transplant is something which is unclear. So if you look at publications before 2000, these were transplants which are done even at the end of the first week of ECMO therapy. Now, over the mid to late 2000s, when bridging or more familiarity arose with the use of ECLS, especially as ECLS as a bridge for waitlisted patients, the duration of bridging and duration of ECMO therapy prior to listing of these acutely unwell patients have actually gone up. So if you look at subsequent publications, now there is more data on patients who have been bridged to 120 days, 145 days, for example, Con et al, etc. The other thing that is actually evident, if you look at outcomes, is these patients, if you look at the published data, the immediate post-transplant outcome has been kind of stormy. They've had several complications described, especially the patients that were bridged for quite a long time. The other thing which is reassuring is that even though the short-term outcomes have a lot of morbidity, the long-term outcomes have been fairly reassuring. So if you look at the 2 main papers which are published, one is the series by Chang, this is from Seoul. They looked at 14 patients who are listed for ARDS and were listed for lung transplant. Only 9 of these 14 patients actually underwent transplant, and the others actually were delisted due to intercurrent illness. Now, these patients were quite young, and when he compared patients who actually underwent transplant as opposed to patients who are not evaluated or not listed for transplant, that is the other ARDS patients, these were younger. They had much lesser comorbidity and much lesser severity of systemic illness, meaning that they did not have multi-organ dysfunction, as could be clearly understood from lung transplanting listing criteria. Now, these patients, the median time to transplant from ICU admission was actually about 1.5 months in these patients. And then 8 of the 9 that underwent transplant actually survived, as opposed to only 1 out of the remaining that did not undergo transplant. But interestingly, there was still 1 patient out of the other 5 that did not undergo transplant that survived. In the retrospective review of UNOS database by Harano, which was recently published in 2020 after the COVID pandemic hit us. So they were looking at kind of similar data that we were looking for. And then they looked in the UNOS database and found 63 patients that were waitlisted for ARDS and for transplant. Only 39 out of the 63 patients actually underwent transplant. And over this period of the UNOS database, starting from 2005 to 18 that they used for analysis, there were actually 25,541 transplants done. So indicating again that this is a very uncommon indication for transplant. Out of the 63 patients, 17 were removed actually for worsening. Very interestingly, 4 actually were removed for improvement. Among the patients that actually underwent transplant, the median age was only 35. And then majority of the patients were actually ECMO bridged, and very few were actually only on oxygen, means high flow nasal cannula. The illness of severity was the last score that we use. Is the higher the score, the more severe the illness is, and the more the net transplant benefit. So this is quite high. Most of our patients would typically have 28 to 30. So this is 88.4. And BMI was the other thing that was higher in these patients, meaning that these patients, you don't have time to to lose weight and do physiotherapy intensely as you would normally use very strict criteria for BMI in lung transplanted listed patients. So out of these patients, majority actually had bilateral. There were very few single lung transplants. 1 in 5 actually had renal replacement therapy during the post-operative course, and there was a 10% hospital mortality. The length of stay was typically like close to a month, and a fair survival of 82% at 1 year and close to 70% at 3 years was reported. Bear in mind that the median follow-up was only 2 years at this in this database. So the main question, of course, in COVID ARDS is actually not if it it can be done, but when should it be done? That of course is the main question, and unfortunately I don't have a very good answer for you, even after looking at the published literature and speaking to people who have been doing transplants for the last 30 years. So if the other way to look around this, and then the database, the UNOS registry actually does not tell us what was the waitlist duration, like how long were these patients on ECMO prior to them being listed for transplant. That is not available in the registry. So that is the one missing puzzle in that. So the other way to look at this is a recent paper for COVID ECMOs, and this is the ELSO's registry. Again, they looked at a large cohort of 1,000 odd patients, of which majority were VV ECMOs. And bear in mind that this was during the first wave. So therapy was significantly different than what it is now. In this cohort, 44% actually required renal replacement therapy, and 6% had an IC bleed. So there are some differences to be considered. Of these patients, the mortality at 90 days was actually 37%. Now, what this paper does not tell us is what is the median duration of ECMO run for this cohort. But what it does tell us is 6% of patients were still in hospital at the end of 90 days. So that is kind of some information that we can expect. That is, if you run ECMOs for these patients, probably about 5 to 6% of your cohort would still be in hospital by the end of 3 months. Now, what we don't know is, are they still on ECMO or are they not on ECMO? So that's the question. So typically in our practice, we get after the COVID era, we have this mild to moderate COVID disease on an underlying ILD flare. Typically, these are listed patients. Sometimes we have unlisted ILD patients who first time present to us with an COVID flare and who kind of fairly decompensate, requiring us urgent, semi-urgent evaluation and then listing. So these would be treated like an underlying ILD with COVID exacerbation. And these would be a kind of a semi-urgent transplant listing. So this is one cohort overall. Now, this is not the subject of this talk. The subject of this talk is primarily patients with severe COVID ARDS, which are typically 5 to 8% of all patients who quickly develop severe ARDS are being ventilated, prone, or on ECMO. Now, we expect recovery by around 45 to 50% of these patients over the next 3 to 4 weeks, death in another 45 to 50%. However, there are probably about 5 to 6% of patients who remain ECMO dependent after 28 days. And these are the patients who we currently consider for evaluation for lung transplant. There is also this smaller cohort of patients who have severe lung disease who are being managed with NIV and HFNC and who persist to continue to require HFNC at very high flows at more than 4 to 12 weeks. A small subset of these patients again crash over the course of the 3 to 4 weeks, requiring proning or ECMO. And a small subset again continue to persist to require HFNC or high BiPAP requirements at the end of 8 weeks. And these are again patients that we consider for lung transplant evaluation. We also have probably, especially after the second wave, a huge load of patients who will have significant lung injury, who have persistent hypoxemia, and who are going to require a lot of oxygen with a lot of fibrosis evident on CT. So we really don't know what is the percentage of these patients, and probably these are patients who are going to be considered for transplant evaluation later on, should they survive. So if you look at guidance from international published or from ISHLT about who one can consider, the ISHLT document suggests that one can consider lung transplant in carefully selected patients if the lung injury has been severe and it's been present for more than 28 days, and there are markers of irreversibility that is primarily seen on imaging and ventilatory studies, and it should be single organ disease, and there should be no active COVID as indicated by 2 negative SARS PCRs or a deep respiratory specimen. And these should otherwise be candidates that could be considered to be transplant candidates by the local transplant center. So there is also a recent kind of experience published from the Northwestern and Chicago, where Ankit Bharat's group. So they looked at their literature from May to September 2020, and in a sort of collaboration with the Gainesville and other centers, one of which was in India. So they have reported on 12 cases, and this is fairly recent. 11 of these 12 patients were actually ECMO bridged, and then only 25% of these patients were actually only trach masking, rest was still ventilator. And then majority of them were actually not able to stand or walk prior to being listed. 83 of these patients, however, were awake, meaning there was a small subset in 2 or 12 which are actually not awake but were still considered for transplant. 50% actually had AKI prior to being listed for transplant. So these patients that are in this cohort, the median duration for listing was actually 69 days with a range of 51 to 82 days, and the time of ECMO was roughly around close to 2 months prior to being listed. And majority, if you look at the CTs of these patients, they showed active complete consolidation of the lung, and fibrotic. In the other 50% of patients had fibrotic changes, and again, as indicated, extensive air leaks and pneumothorax was fairly common in this subset. So, so from the published literature, it's kind of evident that one can consider for transplant if somebody remains ventilator or ECMO dependent beyond 4 to 6 weeks, and there is evidence of irreversibility on imaging. Now, what exactly is irreversibility is something that needs to be better defined. The next piece of the puzzle is to actually rule out an active infection, and that could be in COVID in the recipient. So the ISHLT document recommends 2 samples, one of which could be a deep airway sample, and that has to be negative for PCR at least 24 to 48 hours apart. So what we have and several groups have seen is that PCR can continue to be positive if you do it on follow-up. And we've had anecdotally patients who actually the PCR will continue to be positive, albeit with very low cycle threshold, with very high cycle threshold levels for months together in the absence of any clinical disease. Other groups have shown that with a CT value of more than 28, the virus cell cultures are typically negative, even if the PCR is persistently positive. So we kind of use, in the absence of good access to viral cultures, a time-based criteria of more than 3 weeks from onset of symptoms in severe disease, no evidence of active illness in the form of fever or inflammatory markers, and that BAL PCR should either be negative, or if it's positive, it should be more than a cycle threshold value of more than 30. Also for donor, we use clinical information, a CT chest mandatorily, especially with the current second wave, a nasopharyngeal swab, and a lower respiratory sample in all our donors to rule out COVID, which can be asymptomatic. The other part of the thing is to rule out other active infections, especially secondary infections in these patients who actually have COVID ARDS. So CT chest is actually done as part of the transplant evaluation and all patients at listing. We also use bronchoscopic alveolar lavage, including galactomanins. And then because of the receipt of steroids, we also look at PJPs. We use blood cultures, especially while these patients are on ECMO, and urine cultures, sinus, especially in diabetics and those with steroid receipt. Abdomen, we've had some patients who had asymptomatic abdominal kind of perforation that was picked up on CT. So that's kind of been added to the list of, because clinical examination can be misleading in these patients. And then we also add CMV PCR to quantitative PCR to the list of evaluations that we do routine prior to listing these patients. As far as intraoperative infection is concerned, much has been recommended. However, we are proceeding for lung transplant, assuming that the patient, the recipient, is non-infectious at that point. So the usual sterile precautions for lung transplant is what we usually kind of do. We don't do anything extra in theater. What about exclusions? The exclusions for transplant are the normal exclusions for lung transplant that we usually use. That is acute medical instability, typically due to sepsis in this instance, or of course, due to a recent MI or liver dysfunction. Any history of malignancy, which of course is a own separate entity in itself. So it depends on the type of malignancy and what stage it was. Any other untreatable organ dysfunction or uncorrectable atherosclerosis, uncorrectable bleeding diathesis, or active mycobacterial tuberculosis, or active extremely multi-drug resistant pathogens. Of course, what is also equally important or more important is that the patient should be awake, able to engage in a conversation, should be able to show that they can be adherent to medications, and should not have had any significant psychiatric or substance abuse in the past. There are again several relative contraindications, none of which are actually absolute these days. And then there are ways to get around that as by proper physiotherapy or otherwise. There are very specific bridging requirements when we speak about bridging to lung transplant. And typically, bridging is done for patients who are less than 65 years, should have a single organ failure. And in this instance, we're using a 4 to 6 weeks of recovery at least. There should be evidence of irreversible fibrosis, and we've defined irreversible fibrosis along with other groups as showing fibrosis or severe bullous destruction. As I've actually shown, published literature also suggests that confluent consolidation without any sign of without any significant improvement beyond 4 to 6 weeks has also been used as a sign of irreversible disease. Patients should be awake and able to discuss transplant and should be able to participate in physical therapy. Other standard criteria should be met. The infective criteria we've already talked about. And then this transplant center should actually have had experience with high-risk transplants and should have access to a broad donor pool with a low waitlist mortality, because we should not disadvantage other patients who are waitlisted already.
Dr. Raj, I have to stop you in a couple of minutes if that's okay.
I have a couple of slides only. And then with regards to COVID, given the multi-organ dysfunction, we have criteria in place for kidney protection and other kind of things. Issues about transplant evaluation exist because transplant evaluation is extremely limited in patients who are on life support. But it is important to look at individual organs with special implications related to transplant. Primarily, we do a coronary angiography in all of these patients. The right heart cath is less important. We look at infections, as I've already discussed. We especially look at proteinuria and myoglobinuria, and then we look at sensitization very closely. About immunosuppression, we use a standard protocol. We try and avoid any going across cross matches because desensitization is not an option in these patients who have several infection, especially while on ECMO. And then we use standard prophylaxis. So what about expected outcomes? Now, COVID has affected transplant not directly, but also in myriad other indirect ways. We've had a reduction in routine referrals. Our transplant activity has gone down by 50%. Waitlist mortality is definitely up. COVID as such has become a dramatically increased cause of referral. And now it used to be 30% after the first wave. Now it's about 50 to 60% of our consults now. Actually, less than 10% of these patients can actually be evaluated for a transplant. Majority have an obvious contraindication. There is the definite immunosuppression risk during a pandemic. There is donor screening has become complex with the turnaround time for BAL PCR and the short times available before a transplant. Healthcare system is inundated. We don't have any COVID-free floors. And as I've indicated, even small centers like us had to grow fast because our normal transplant activity is now COVID transplant activity. Healthcare exposure risks and transmission risks exist, and this is something that we should consider for our recipients that are in hospital. And then apart from other things, even the routine care after transplant becomes complicated by the fact of limited outpatient reviews, PFTs, etc. available. So we looked at our data of more than 224 patients referred to us over the last 4 months. And as you can see, 1/3 of these were actually COVID referrals, and this was before the second wave, of which majority had one contraindication at least. Again, more than 78% unable to get a PFT in recent times because most PFT labs are still shut down. And then, as you can see, most of these patients were referred quite late. 10% actually died before the second review, even before we could do anything. Of the patients who did complete this review, when we followed up patients over the next couple of weeks, 1/3 had actually died. And then 25% were waitlisted for transplant. Of these patients, we were able to transplant 11, and 3 were transplanted in another center close to us. We lost some patients on the wait list, and then we have some patients who are awaiting transplant while being bridged or otherwise. So this was the first patient that we discussed, and then this patient continued to be on ECMO, and then at the end of day 28, as you can see, completely flooded lungs, showing only complete air bronchograms. So this patient was at this point underwent transplant evaluation and listed by day 30, and by day 38, a lung became available. This is the explant. The subsequent course was complicated by several things. She had a bilobar transplant because of size mismatch. She was extremely sensitized, so we accepted this size mismatch with a bilobar transplant because her virtual cross match for this bilobar transplant was actually negative, and the chance for getting another one seemed remote. She had post-operative complications in the form of grade 3 PGD with RV dysfunction, so she had to remain on peripheral VA till day 3. That was converted on day 3 to VV ECMO peripheral, and then that was decannulated by day 7. She remained on the ventilator with slow weaning. She developed a pleural hematoma by day 7, so she had to undergo a hematoma evacuation by uniportal VATS. Around this time, she also had hyperammonemia post bilateral lung transplant, which is a well-recognized entity in itself. And around this time, she also developed Candida tropicalis empyema with bacteremia. So, and she also subsequently developed bronchial dehiscence requiring a stenting, which was subsequently removed. So she still remains in hospital, tract masking, able to sit out in bed and doing active rehabilitation, but still requiring about 2 liters oxygen. And this is another patient that we've done, which was actually, he was managed with BiPAP with very high FiO2s for about 5 weeks in another hospital, and developed a Acinetobacter pneumonia at the end of 5 weeks, became dependent on the ventilator for about a week and referred to us at the end of 7 weeks. So required ECMO at that point, and was bridged to transplant after 26 days of ECMO. And this is explant. This is the pathology showing various kind of findings, which I will skip for now. So he underwent transplant on day 75 of bridging. He was not sensitized. Post-operative complications, actually, he was quite quickly decannulated and off the ventilator by day 3. He had AKI, which was due to ATN, which subsequently he improved. And then he's being discharged by day 45. These are a couple of other patients with scenario 3 and 4 that I kind of described. These are patients who had lung injury, but not severe, not requiring ECMO, but hypoxia. Subsequently, extreme architectural distortion, continuing to require oxygen at 3 to 4 months. This is the kind of published literature. These are the media reports highlighted in yellow, and this published literature kind of seen in blue. The literature that is available shows about 15 patients, but probably about 80 patients have been transplanted worldwide. In the published literature, 11 out of the 12 in the series by Ankit Bharat were alive in the short term. The medium and long-term data has yet to be published, which are looking for as the time progresses. There is also this ICT abstract again from the same group published, which updated their data with about 17 patients, of which 16 are alive, indicating good outcomes. In our own series, we've done 2 primary for COVID and 2 for COVID exacerbated ILD, so of which 3 out of the 4 are alive at 3 months, of which 1 is still in the hospital at day 61. Yeah, anecdotally, other centers have also done a fair number in India. One center has done about 28 of whom are alive at 6 months. So again, more robust data, peer-reviewed is needed, and more data on medium and long-term data is needed to see if these outcomes are inferior to ECMO-bridged outcomes, which typically have a 75% 1-year survival and 65% 3-year survival. So in conclusion, lung transplant, this is my last slide. Lung transplant is a feasible option for COVID ARDS. The timing of listing is controversial, and there is bridging is probably patients can be considered for transplant at 4 to 6 weeks from lung injury and not necessarily onset. ECMO bridging with awake strategies is crucial. Immunosuppression should be standard, and more data is needed on ARDS cohorts with decannulation times in non-transplant centers to decide on who and when should be considered for transplant. We also need more markers of irreversible lung injury and more support systems to mobilize patients on ECMO better while bridging them for transplant. And thank all members of my team who made this activity possible. Thank you.
Thanks very much, Dr. Rajgopalan. An important talk. Sorry, we're running a little bit over, and hopefully people can refer back to it on the channel for reference. Okay, so I'm going to move on to the last couple of talks, so that we're going to probably ditch the Q&A session because of time, and we'll try and move on to the last couple of talks. Thank you very much, Dr. Srinivas. I'm going to introduce Dr. Rachel Evans, my colleague at Glenfield, who's an associate professor and consultant respiratory physician, and she's the co-lead investigator for the UK-wide post-hospitalization study post-COVID called Phosphor-COVID, and she's also been involved in setting up one of the first dedicated long COVID clinical services, which reviewed more than 1,000 patients. She's also on the NHS England task force for long COVID. So Rachel, thank you. Thanks for joining us.
It's a pleasure to be invited to talk today. So is that sharing my screen?
Yes, Rachel, we can see it, thanks.
Yeah, lovely. Great. Okay, so a little bit of change of pace now. So you've been hearing all about the acute scenario, and I know you're heavily embedded in that at the moment. And I'm mindful of that while talking then about what happens afterwards. And this is more of a research-based talk rather than practical experience. But as Rakesh was saying, I do also run our long COVID service. So if you have got questions around setting up a service or anything like that, I'm very happy to be contacted another time about that. You don't need me to tell you about what happens during the acute phase, and I know others have already gone through the risk factors of a poorer outcome during that acute phase. The reason that I'm highlighting the predictors of a poor prognosis or poor outcome from the acute event being older age, male, obesity, social deprivation and comorbidities is you do need to be mindful of the survivor bias when we're only looking at survivors of a hospital admission in long-term cohort data. Now, unfortunately, not unfortunately, the paper was published, but unfortunately, this paper that looked at GP level data, and that's primary care level data, family practitioner level data in just under 50,000 patients, did show quite a high level of mortality and morbidity even after the hospital admission. So 1 in 10 patients had died within 3 months of discharge, 1 in 3 had a readmission, and 1 in 5 had a new respiratory problem. Now, when you're looking at those control data, you do need to be mindful that that is a non-hospitalized population. And we know that COVID-19 isn't just a disease of the lung, it is a multi-system disease, and the same data set did show new onset data for diabetes, major cardiovascular events and chronic kidney disease in survivors of a hospital admission with COVID compared to healthy controls. The patients with COVID that were hospitalised are in purple and the controls are in orange on that slide. And because of that, there's a new UK-wide study that's literally just starting to recruit now across the UK called HEAL, and that's helping alleviate the longer-term consequences of COVID-19. And this trial was really set up to help with that early morbidity of hospitalisation and mortality. And it's an adaptive platform design. The primary outcome is hospital-free survival within 12 months of follow-up. The secondary outcomes are all-cause mortality, hospital readmission, suspected serious adverse reactions, and a host of patient-reported outcome measures. And very briefly, the trial will start recruiting patients at discharge from hospital, and patients will be randomised then to either usual care. At the moment, arm 1 is atorvastatin, so going home with a year of atorvastatin, or arm 2 is 2 weeks of therapeutic dose anticoagulation. And the idea is to see whether or not those drugs will help with hospital-free survival within 12 months of follow-up. The adaptive part of the trial design, that means that as we get new data or think that other medication might help, that can then be added into arm 3. So just so you know what might be coming out over the next year. Now, for the NHS, the NICE defined long COVID in a whole series of documents in terms of acute COVID being signs and symptoms of COVID up to 4 weeks, ongoing symptomatic COVID-19 from 4 weeks to 12 weeks, and then post-COVID syndrome, anything after 12 weeks. And again, this is expert advice. NICE have really, tried to do their best by trying to help us at least almost be able to talk in the same terminology, but at the moment there isn't really science or known clinical syndromes underpinning those definitions, so they may well change over the coming months. And long COVID, as you may well be aware, is very much something that's come from patients themselves, and they are very terminology. They feel that the acute illness isn't always very clear to define for them, particularly when they've had it in the community and not necessarily come to hospital, that the start and finish of the acute phase is less well defined, and that's why they prefer the term long COVID. And this is the guideline that NICE has produced is a living guideline, so it will be iterative when new knowledge is known. So what do we know about the symptoms after a hospital admission from COVID-19? And this data came from Italy really very quickly, a few months after the pandemic, and was one of the first to both highlight the persistent symptoms, but also that it is probably slightly different symptoms that persist rather than the ones that you have during the acute illness. And for lung physicians, certainly seeing that cough largely resolves over a couple of months was really reassuring. So if you look at the data on the right of that graph, it's fatigue, dyspnea and joint pain that really seem to be the most persistent symptoms. And as I said, that is just at 2 months. So when we look at a few different cohorts that have all been published, in the community, fatigue, breathlessness, headaches all seem very persistent at 2 months, and that data is largely driven by a symptom-based app, again across the UK, but also some in Sweden and some in America. And then this data is from our study through the FOS-COVID consortium, and at 5 months after discharge, these were the top 10 symptoms. So muscle pain really coming to the top, fatigue, physically slowing down, impaired sleep quality, joint pain, limb weakness, breathlessness, pain, memory loss, and slowing down in thinking. And when we're thinking about what sort of support people need after a hospital admission with COVID, we do need to be mindful of these symptoms. But it's not just the type of symptoms, it's actually the total number of symptoms. And I think this is really very striking to clinicians involved looking after these patients, that the mean number of symptoms is 9. And that's obviously very burdensome for the individual, quite difficult to, or brings challenges into clinical care. So looking at the trajectory of recovery, most of our data sets so far go up to 6 months, and we're really just waiting to see really what the 1-year data looks like. And the same in clinical service, we're literally only just starting to see those admissions from March, April last year come through our clinical service. So this is the data that I showed you before, that 87% of people still had persistent symptoms at that 2-month mark. This is some data again from England in a cohort of just under 200 people, showing 74% of people still had persistent symptoms. This is data from a study in France at 4 months, showing that 50% still had new symptoms after a hospital admission. And our data from FOS-COVID, which is a multi-centre study across the UK, showed that in a data set of over 1,000, that 50 to 70% of people still don't feel fully recovered at that 5-month mark. And a very large study from Wuhan in China also showed at 6 months that 76% of people still have persistent symptoms. And as I've said, the 1-year data is really unknown to try and understand how much of this symptom burden and impact actually does resolve at 1 year. But there are some bits of good news, and certainly this paper highlighted what we're seeing in clinical care very well, that actually even though there's symptom burden and a lot of negative impact on the individual, actually the acute lung injury, certainly on chest x-ray, predominantly does seem to resolve. The RAIL score was a way of scoring the infiltrates on a chest x-ray, and you can see they've marked out the the amount of shadowing at admission, the worse that they had during their inpatient stay for those that had repeated x-rays, and the follow-up x-ray patterns, as you can see, is much improved. And they also showed that there were persistent symptoms and impacts on mental health and physiological impairments at that 2-month mark. But actually the follow-up chest x-ray findings were quite a poor marker of that recovery. There's very little CT data in large cohorts of patients at the moment that's published, but certainly clinically, the majority of patients do seem to get resolution from the lung injury. Again, we're waiting to see on follow-up scans how much persists. So the risk factors associated with prolonged symptoms or long COVID, from the symptom app study that I mentioned before across 3 different countries and in over 4,000 people, showed that at the sort of 2-month mark, older age, female sex, and experiencing more than 5 symptoms during the first week were markers of having ongoing symptoms. Data in a much larger data set from the UK, from the Office of National Statistics, is doing a massive follow-up questionnaire study, and this data is in nearly 7,000 patients. People, sorry, they're not all patients, that they've showing that symptoms at 3 months are much more common in those sort of working age groups, 35 to 70, female gender, in those with more social deprivation and in pre-existing comorbidities. And when we did a regression analysis simply based on whether or not people felt fully recovered or not, we also showed a relationship with age. And if you look at the odds ratio on this forest plot, anything going to the left means that you're less likely to recover. And you can see that there's really very much a U-shape relationship with age, with those middle that are less likely to recover. Female gender, having 2 or more comorbidities, being invasively ventilated, being that ill when you were acutely unwell in hospital, were all more likely or more associated with not being fully recovered at 5 months. And I expect it's been covered today, the recovery trial and how beneficial steroids are to help the severe illness acutely. But in this data set, on this crude measure of just patients, whether they feel fully recovered or not, there was absolutely no association with whether or not people had received steroids. So for the National Health Service across England and parts of the UK, they put together this 5-part package of measures for NHS support for long COVID. And I just thought I'd highlight this so that you know what's already available in the NHS and what may already be available as well for things that you can use for your patients if appropriate. So there is the NICE guidance, as I said, that's very iterative, that they will be adapted as we have new knowledge. There's a Your COVID recovery platform. It is in English, but it is public facing, and that would be available, and certainly we can share the details of that. There's a phase 2, which is a bit more involved programme with physical and mental health recovery. It involves a 6-week programme with a multidisciplinary team. There are now designated long COVID clinics across the UK. And again, if anyone's interested, I'm very happy to go through how these run and what sort of assessments that we take part. The NIHR, which is our NHS funded research on long COVID, involves the FOSS COVID study that I am going to talk to you about today. But there are also many other studies being funded around long COVID for people in the community that haven't come to hospital, and both for cohort studies and for interventions. And there's a long COVID task force. As part of the FOSP study, we really wanted to learn from clinicians of what they were finding in clinical care to adapt our research programme. And likewise, anything that we were finding in research, we wanted to feed back directly to relevant clinicians. So we set up this series of webinars. They are all recorded. They're not publicly available because they're very much clinicians talking to other clinicians and researchers about how to manage this group. But we would be very willing to share those with you should they be helpful. So to tell you a little bit more about the FOSP COVID study, it's running across the UK, it's multi-centre and it's an integrated research and clinical platform. Our aims are to determine the short to long-term sequelae of COVID-19, the impact of interventions both acutely and post-discharge, and to be a platform for further in-depth studies. The study design is quite straightforward. The first part of the study runs for a year, and there's a particular tier that patients can recruit, that patients can volunteer to participate in, and that involves a research visit at 3 to 7 months. I'm showing you some of that data today, and then a follow-on visit at 12 months. And the point of the whole study is that we're doing a holistic assessment. It is patient-centred and it is focusing on patients that have been hospitalised. So this is the data for our first 1,000 participants. The mean age was 58 years old, over a third were female. Just under 70% were white. The important part is 68% were still working. So we have to be mindful of that when we're thinking about these long-term sequelae. Over half were categorised as obese, which Caroline's also mentioned fits with her experience on the ICU. Over half had 2 or more other existing health conditions, and these were namely heart and lung diseases and type 2 diabetes. For the acute therapy, we had a good spectrum of those that hadn't required oxygen, those that had required invasive respiratory support. Only a third had been prescribed steroids, and that probably features that some of these patients were discharged between March and April last year in our first wave. And at that point, we didn't have the recovery trial, so steroids were predominantly prescribed in the ICU. Over 80% was prescribed antibiotics, and just under a third were prescribed therapeutic anticoagulation. And most of that prescription of anticoagulation and steroids was within those receiving mechanical ventilation. So our patient-reported recovery at 5 months showed that only 1 in 3 felt fully recovered. The median number of symptoms was 9, as I stated earlier. Just under 1 in 5 were no longer working, and 20%, or just under 20%, had experienced a health-related change in occupation, and 20% had developed a new disability. For the impact on mental and physical health, over a quarter of the cohort had clinically persistent symptoms of anxiety and depression. 12% had symptoms of post-traumatic stress disorder. 17% had at least mild cognitive impairment measured on the MOCA score with a score of less than 23, and 46% had reduced physical performance either on a shuttle walking test or on their short physical performance battery measured by what you would expect for their age and gender. As far as organ function, fitting really with that description that the chest x-ray findings largely resolve, 31% of the cohort had impaired lung function, and these data for organ function don't take into consideration pre-existing comorbidities. So putting that another way is that nearly 70% of the cohort actually had really quite good lung function, so an FEV1 over 80% predicted and a transfer factor over 80% predicted. 35% had pre-diabetes or diabetes, 13% had abnormal kidney function, and 7% had a raised brain natriuretic peptide at the level consistent with the need for investigation for heart failure. Now, not surprisingly, the lung physiology and walking test data were worse in the group who received invasive mechanical ventilation, as we would expect that that group will take longer to recover. But what we were quite surprised at was that there wasn't a clear association between the symptoms, the mental health, the cognitive impairment, and other measures of organ function with the severity of the acute illness. And we went on to do a cluster analysis, which I'm not going to present today in the interests of time, but I can certainly again share that with you. So as summary, implications for clinical care, that there is unfortunately significant post-hospital mortality and morbidity, and the HEAL COVID study is ongoing to investigate if there are treatments at discharge from hospital that will reduce that. That a majority of patients do have persistent symptoms at 6 months after acute illness, that those symptoms are not closely related to the recovery of the acute lung injury, and the underlying mechanisms for that are being investigated. And although there is a large range of clinical problems at that 5-month mark, including comorbidities, we're awaiting really the 1-year data, both clinically and from FOSP and other cohort studies. Thank you.
Thanks very much, Rachel, for that. I think a lot of colleagues in India are probably going to be seeing patients with long COVID, if not already seeing them, and I think it'd be useful for them to really follow the outcomes of your research and to keep on track with it. So thanks very much, Rachel. I'm sorry we've overrun, but thank you very much for participating at short notice. I'm just going to introduce our last speaker for the last 15 or so minutes. It's Dr. Nitesh Gupta, who's an assistant professor and nodal officer for the coronavirus outbreak at the Department of Pulmonary and Critical Care and Sleep Medicine at the VMMC and Safdarjung Hospital in New Delhi. Dr. Gupta, thank you very much for joining us, and apologies we're sort of overrunning, but I think this will sort of tie in the program very nicely. Thank you very much.
Good evening, sir. Greetings from India for all the UK colleagues. I am at the outset, I'm thankful to Yashoda Hospitals and University of Leicester for the opportunity. I would be talking on current and future research in COVID-19. I do not have any conflicts of interest. So when you start searching the research in current COVID era, when you go to the world's most popular research engines, the PubMed and the clinical trials, just typing COVID-19 gives you about 1.4 lakh results. And in clinical trials, you have almost 5,800 results currently as of today. In comparison, when you type tuberculosis, over a past 140 years of history, you just have 1.67 lakh results and only about 1,000 trials going on. So we already have a huge data to search for, and we are now looking for the future. The outline of my talk would be domains of research in COVID-19, beginning from diagnosis, the pathophysiology, prevention of COVID-19. Can we predict the progression of the disease early, treatment, and post-COVID-19 recovery? So for diagnosis, we already have, for acute infection, we use nucleic acid amplification tests. For mechanical ventilation, we again use nucleic acid amplification test as first test of choice, followed by endotracheal aspirate, and lastly, if diagnosis is not achieved, a bowel sample. For a diagnosed case as reinfection, we need a symptomatic patient plus a nucleic acid amplification test. The recommendations are strongly against use of serological tests for the basis of diagnosis, and recommendations are against the use of serology to determine whether a person is immune to infection or not. No levels of antibodies have been shown to be protective. Antigen tests are less sensitive but more specific compared to NETs. Should be done especially in symptomatic patients and avoid in asymptomatic patients. And with the variants coming up, the sensitivity is falling further for these antigen tests. Can we use any other sample apart from the current existing upper respiratory tract samples? There has been study on the saliva collection of saliva samples. It was found out to be concordant in 98.2% of patients. So for future research, what we are looking for volatile organic compounds. There are already 2 trials going on. One is COVID-19 breath test. Another is bioelectric nose, AO nose. They both are based on volatile organic compounds detection in COVID-19, and both the results are expected later part of this year. In pathophysiology, as the COVID-19 has evolved over the last 1.5 years, we have now realized it affects all the components of the pulmonary circulation, the arteriole, the venuole, the bronchiole. So patient may have hypoxemia, right from being a VQ mismatch right to the spectrum of being a shunt. because of thrombosis, edema, and later on because of fibrosis. So the study question comes, are critically ill COVID-19 patients biologically and logically dissociable based on profiling of currently evaluated therapeutic targets? This paper was recently published by DuPont et al. In just last month only. What they studied about 100 patients of their COVID-19, and they did the immunological markers which are available. And to the surprise, there were 3 clusters which were identified. The cluster 1 was which was humoral immunodeficiency phenotype, where the B lymphocytes were deficient, hypogammaglobulinemia was observed. The second was the usual one which we know is hyperinflammatory phenotype, which is said to be steroid responsive. And third phenotype which was identified was complement dependent phenotype. So is the steroid non-responsiveness in current variant of COVID-19 related to these clusters? We are yet to elucidate that. And so such immunological variability argues in favor of targeting different mediators in different groups of patients. And this could serve as a future for patient identification in clinical trials. For prevention of COVID-19, there are general prevention measures which are human behavior, which we all are now very well aware of. Lockdown is an effective measure, but again, it has major social and economical impact. And the prophylaxis, which can either be pre-exposure and post-exposure, can be subdivided into immunoprophylaxis, that is vaccines, and chemoprophylaxis. So general preventive behavior, as of current understanding that the SARS-CoV-2 is aerosol generated and spreads through respiratory droplet. Hence, key control measures includes respiratory hygiene, physical distancing, and mask. But in recent publication from Lancet suspects it to be airborne. That is, it may spread through exhale, spread, shouts, sings, or sneezing. So this is also said to be the increased transmissibility factor. If this is proven, if the theory is proven of it being airborne, then we will have to add two key control measures, that is ventilation and air filtration, to our current behavior practices. Moving on to immunoprophylaxis vaccine, we have a plethora of vaccines. Almost about 100 vaccines are in trial, and about 6 or 7 are currently have been given emergency use authorization. The current efficacy is about 60 to 95%. Population mainly being 18 years and high risk group as the first target. The real world data also evaluates the data from the trials. The Moderna and the Pfizer vaccines have shown to be about 90% effective. And Moderna and the AstraZeneca Chadox vaccine has again shown hospital prevention in about 90% and mortality reduction in also about 80 to 85%. So vaccines do work. So anybody who is listening and not getting and has not yet been vaccinated, so please should go and try to get vaccinated at the given opportunity. So what will be the future for the vaccines? We have 5 questions to answer. Are they effective in children, pregnant, and immunocompromised patients? Can we mix and match the vaccines? What about the emerging variants? Will the current vaccines work? How long will the protective effect of vaccines will last? And can we try a different route of vaccines like a nasal spray? So this was a recent finding from the registry from the US, where they did not find obvious safety signals in pregnant patients who had received the mRNA COVID-19 vaccine. The further studies are still underway. So when we talk about immunodeficient, there is a COVAXIT trial going on. For pregnancy, there is a COVID price trial going on. And the availability in healthy children less than 12, there's again a trial going on. The results are expected by next year. Even in India, the trial is expected to start somewhere in June for the Covaxin vaccine. Vaccine efficacy against the variant is definitely there. There's a slight fall after the two doses from 93 to 87 for the Pfizer vaccine. And for the AstraZeneca vaccine, it is from 66 to 59. Yet it is still a very effective measure to control the pandemic. Going by the route of administration, there is a study of molecule MB014212, which is said to be intranasal drops. Then the Covaxin also has initiated the nasal spray. The recruitment has yet to start. And there is a Razi-Cov-Pass vaccine, which is again nasal spray, the results of which are awaited. Mixing and matching vaccines. There is a mosaic study which is going on. It includes the Sinopharma vaccine, the Moderna, the Pfizer, and the AstraZeneca vaccines, and they have made various subgroups to see whether the mixing and matching is as effective as giving a single vaccine in twice doses. So research on vaccine is a continuous process. and is a very important integral part for the pandemic control. Now, for pre-exposure prophylaxis, the guidelines are recommend against any use of any drug, be it HCQS, be it ivermectin, or even monoclonal antibodies outside the clinical trial. The HCQS was rejected on the basis of PrEP study and a study published in JAMA. Both of them were underpowered, and because of poor enrollment, the results were not comparable. Still, we continue to search for the pre-exposure prophylaxis for the COVID-19. Both HCQ and ivermectin trials are still going on. For the HCQS trial, the results are awaited. For the ivermectin trial in Dominican Republic, by the end of May. For monoclonal antibodies for COVID-19 as a pre-exposure prophylaxis, again, Regeneron 2 molecules, combination of 2 molecules. The trial is yet to recruit. And there's a molecule by ADM03820, which is an IgG1 non-competitive binding of anti-SARS-CoV-2. Its phase 1 trial has started to look for serious adverse events. Going by the local method, if the virus enters through nose and then from upper respiratory tract goes to the lower respiratory tract, why not catch it at the beginning only? So povidone iodine nasal spray and gargle study is being going on, known as PIIPI. And there is a niclosamide nasal spray study, which is known by the name of Protect 3. Again, the results are expected by the end of next year. Now, what to do if a person gets exposed to a COVID-19 patient? Again, as per the guidelines from NIH, it recommends against the HCQS and monoclonal antibodies, hypergammaglobulinemia, plasma, ivermectin. They are again investigational and under trials only. They should not be given as the component for post-exposure prophylaxis. HCQS has been recommended against based on the trials published in NEJM. What more we have for post-exposure prophylaxis? Again, nitazoxanide versus placebo. The trial results are expected anytime soon. There's a nitric oxide generating solution by the name of RESP-301. The results are expected by next year. Now, there's a trial on favipiravir where they have given in a long-term care facilities to all patients who are exposed. So the end point of the trial is no new case in residence for 24 consecutive days for up to day 40 after the start of prophylaxis. These results would be very interesting. And then there is again a monoclonal antibody as in pre-exposure. Again, a trial is going on in a post-exposure prophylaxis also. Now, can we predict the progression of the patient based on the parameters which are available at a point of time? So there are, humanly, I don't seem it is possible when you can see a patient on day 1, what will happen on day 10. So you need the help of artificial intelligence, where you combine a large amount of data of those patients who have progressed and of those who have not progressed. So there are again 2 studies going on the same pattern. One is machine learning versus machine-based evaluation. Both combine the clinical, biological, and the quantitative or qualitative CT-based data to predict the progression of disease from a mild to severe category at the onset. Now, for treatment, Dr. Pranav has already exhaustively covered the entire topic. I would be doing just in a color-coded pattern. The green is for recommended, orange is for against, and gray is a gray zone where we are not sure whether it is for or against, is the insufficient data. So 2 main processes are thought to derive the pathogenesis of COVID-19. Early phase, we all know, is a viral replication, which is again an outpatient management of COVID-19. So as per guidelines, what is recommended currently is supportive care, telehealth before patient receives in-person care, and monoclonal antibodies, which we have learned that we have started in India also. 2 patients, one in Gurgaon and one at the Yashoda Hospitals, Hyderabad, Dr. Hari Center has given it. We hope the results are all positive. Recommended against for outpatient management is chloroquine, hydroxychloroquine, dexamethasone, or antibacterial therapy. They all are totally out. They are contraindicated and should not be given. So the 2 new things which we look for inhibiting the viral replication, molnupiravir. Again, we are looking for viral clearance after the oral administration of the drug. The trial is end COVID. Results should be there by next year. And the PESCO trial, where favipiravir versus placebo is being given. The results are expected at the end of this year. Now, for the later phase, there is a dysregulated immune or inflammatory response. This is the cause of tissue damage, and this is where patient becomes moderate or severe. This is an inpatient management. So drug of choice is antivirals in which remdesivir is approved. Chloroquine, hydroxychloroquine or antiretroviral drugs are again out. Ivermectin is in a gray zone. Anti-SARS-CoV-2 antibody products again for the inpatient management of mild to for moderate disease have been approved. They are a combination of Regeneron, which is casirivimab and imdevimab, and belimumab plus estezimab are the drug of choice. Convalescent plasma, even after the last trial results of recovery, they are still it was not favorable, and hence it is to be kept out. Anti-SARS-CoV-2 specific immunoglobulin are again a gray zone. Now, more for anti-SARS-CoV-2 antibody products, there are more than 80 trials registered on clinicaltrials.gov. Out of them, 18 are in phase 3. They act against various agents of the SARS-CoV-2, like antibody against the S protein, and which is Regeneron therapy and belimumab versus combination Regeneron versus belimumab plus estezimab. Then there is a new new monoclonal antibody, which is lenzilumab. It is IgG1 kappa factor. It targets the GM-CSF simulating factor. Moving on to as discussed earlier, there are 3 clusters. So we have to target the complement mediated pathway also. So revelizumab is the one which binds and prevents the activation of complement pathway. Then there is a PDE4 inhibitor in the name of apremilast. And there is a zilucoplan, again, which inhibits the cleavage of complement 5, which is again a factor in subgroup of patients. Mavrilumab, anti-GM-CSF receptor alpha. It is again used for critically ill patients, and the endpoint of the study is participant alive and free of MV at day 29. Now, immunomodulators. Baricitinib in combination with remdesivir, where currently corticosteroids cannot be used as approved. Looking into the future, can we just use baricitinib alone, or can we use baricitinib with remdesivir, and how will it fare with remdesivir with steroids? So Act 4 trial will give us the results of baricitinib with remdesivir versus remdesivir with steroids. And Cove Barrier is a study which is evaluating baricitinib versus placebo. Both have the endpoints of death or hospitalization on IMD ECMO. Steroids, we all know it's the golden arrow which has helped us prevent mortality world over. However, when steroids are drug of choice, we have few questions in our mind, like whether high dose versus low dose, what should be the timing of steroids, can we give the prophylactic steroids, what should be the end point for the steroids. So we have got 5 important studies coming up at the end of this year. One is prophylactic corticosteroid to prevent COVID-19 storm, where MPS has been used, and the outcome remains complete, clinical complete response criteria. The timing by early and late means if you have a patient is not clinically moderate, but your lab confirms inflammation, versus late where actual clinical signs appear. There the outcome remains hospitalization. Low dose DEXA is the standard dose as per recovery trial, which is 6 mg per day for 10 days. And high dose DEXA is 20 mg per day for 5 days, followed by 10 mg for 5 days. It is going to look after the death or hospitalization on IMV or ECMO. Then comparison of dexamethasone versus prednisolone for 6 mg versus 60 mg. The most awaited would be the steroid dosing by biomarker, which is CRP guided, where if CRP levels falls less than 50, you stop. And if it is between 50 to 100, the dosing remains 0.5, and you gradually increase as the CRP levels increase. Tocilizumab with dexamethasone has been approved after the results of Impacta, Covacta, and ZMAP-CAP studies. However, tocilizumab versus CRRT again is an interesting study where they are saying we can remove cytokines via CRRT also. So that is a TECO study. And remdesivir plus tocilizumab versus tocilizumab alone, where the outcome would be the change of mu score of 2 or more maintained for 24 hours. The drugs which are already out, so should we stop using them or should we look further whether they can work other or not? Again, baricitinib without remdesivir is currently not indicated. So we have a COVID barrier trial where they are comparing baricitinib versus placebo. Colchicine for hospitalized patient after the GRECO-19 trial is out of the list. So there is a trial by the name of Colstate, which is studying standard of care versus colchicine plus statins. So statins have been added with colchicine. Interferons alpha and beta after the Act 3 trial results is low down the list. So the study has now been changed to pegylated interferon alpha 2b and interferon beta 1b in combination with remdesivir. Both look at the change in clinical improvement. the kinase inhibitor, apart from baricitinib, none of them have currently been approved. So Bruton tyrosine kinase inhibitors like ibrutinib and Janus kinase inhibitors like tofectinib. So both are available in market for all, but they are not as per guidelines. So there are studies which are going to look, the of interesting would be placebo versus tofectinib, which looks at the disease severity as an outcome. Non-SARS-CoV-2 immunoglobulin are again out. So we are now trying to look the SARS-CoV-2 specific IVIG, which is anti-COVID-19 intravenous immunoglobulin. Then there is a high dose IVIG apart from the routine dose. Sarilumab is again an anti-IL-6 which is contraindicated in patients who do not require ICU or mechanical ventilation. So a study by name of SARS-CoV is going on for the same. And for siltuximab, again, combination of siltuximab with steroids is now being tried, and the outcome remains the ventilator-free days. The drugs which are in gray zone, so to get them out of the gray zone to either green or orange zone, we need to look for further studies. Fluvoxamine anti-inflammatory properties were used, as well as the depression and anxiety was found to be less in the current trial. So there is a stop COVID trial for mild patient, and for moderate COVID, there is another trial going on. We may have results by the end of this year. For interferon beta, now the word is coming out to be interferon lambda is being tried, and interferon alpha 2b. IL-1 inhibitor anakinra, it is again being tried with ANACOVID DS study, where anakinra with standard of care is being given as per the protocol. Vitamin C, vitamin D, and zinc are the gray zone. They should not be given beyond the daily requirements. That is the statement which we need to emphasize for any patient whom we are prescribing these drugs. Now coming to future therapies, whether they are cell-based therapy under evaluation, which are actually the your mesenchymal stem cells, your natural killer cells, fibroblasts. They are very costly therapies, hence trials have very few numbers of patients. You can obtain cells from peripheral blood, from oral tissues, adipose tissue, menstrual blood, or bone marrow, and then it can be extracted and prepared, and then it can be infused. So there are almost about 100 cell-based clinical trials. Initially are in phase 1 and 2. Only 2 studies have moved to phase 3. Data is again limited to reports and small open label studies, hence currently not recommended for treatment of COVID-19. Now plasma, since plasma has been, even after many trials, plasma is out of the favor and has not been recommended. So there is a therapeutic plasma exchange to alleviate hyperinflammatory condition, where they are doing plasma exchange sessions, 3 sessions for 3 consecutive days, and looking at the rate of intubation and invasive ventilation. And there's a hyperimmune plasma, that is plasma obtained from convalescent antibodies of COVID-19 infection. This is also underway. Radiotherapy trial, which came initially from Israel, where they said that radiotherapy can be used for the severe cases. So a trial is underway where a 0.5 gray in single fraction is being given, and the change in PF ratio is being studied for the same. Antithrombotic therapy is as important as your steroids and as your antiviral therapy. Currently, coagulation markers have no role in non-hospitalized patients. In hospitalized, there is a gray zone whether the treatment should be directed according to them or not. Anticoagulant and antiplatelets should not be initiated in a non-hospitalized, but hospitalized. A prophylactic dose is recommended. However, as Dr. Pranab mentioned, that institutionalized protocol can be there, and a high prophylactic dose can be there, which is an intermediate dose between high and therapeutic. The anticoagulant should not be routinely given for VT prophylaxis on discharge. The scores which we can use is improve VT if more than 4, or a combination of VT and D-dimer if both are more than 2. So we are waiting for the results of active 4 trial, where therapeutic versus prophylactic versus therapeutic and prasugrel is being used. Then there's a CARE trial where NOAC rivaroxaban is being given. IMPACT trial will help us give more results on intermediate versus therapeutic dose heparin. And Michelle trial is the one which is being tried for oral anticoagulant at discharge and seeing VT at the end of 35 days. Then instead of an injectable form, nebulized heparin is also being tried, the Charter MT trial, where unfractioned heparin is being given, and the outcome is alive and ventilator-free days in severe COVID-19. For improving oxygenation and ventilation, there are 2 trials. COVID trial, which compares the ARDS net strategy versus the driving pressure strategy as derived by electrical impedance tomography. And there is a lung protective ventilation which is less than 6 versus ultra lung protective ventilation less than 4. It is looking at the composite score based on all-cause mortality and ventilator-free deaths. For improving oxygenation strategy, was a new device known as a double trunk mask, recently published in Respiratory Care, where they combine the HFNC with the nebulizer mask and attach a two tubes, corrugated tubes of 15 centimeter each. The initial study had shown that it raises the PO2 without raise in CO2 levels. And if a patient is not able to oxygenate at the normal levels, can we try a hyperbaric therapy? Yes, there's a trial going on with hyperbaric oxygen therapy also, which is being given at 2 atmospheric pressure, and the outcome would be at the 7 level COVID ordinal outcome scale of WHO. Post-COVID-19 management, Dr. Eshel has discussed in great details about how to go about them. I will just be summarizing them in slide. This was a paper from Lancet from Wuhan University recently, where they have studied 86 patients, out of which 83 completed the study, and 3, 6, 9, and 12 months respiratory outcomes were noted. Only a minority had the PFT, DLCO, and your radiology changes at the end of 86 years. At the end of 1 year, DLCO recovered to 88% in majority of the patients, which is an excellent thing. So studies which are going on for the prevention of fibrosis in COVID is pirfenidone versus placebo. Colchicine again makes a space in this place. Nintedanib or nintedanib as expected is there. However, surprising is the Pincer trial, the pirfenidone versus nintedanib. The trial never happened for IPF, but is underway for COVID-19. For thromboprophylaxis post-COVID, post-hospitalization, there is a trial for apixaban, 2.5 mg BD dosing for 1 month. And again, the score remains composite outcome in forms of MI, embolism, DVT, and results are expected by September 21. So as I see, pandemic is once in a century. We see it as an opportunity to dig in the past, stay in the present, and work for the future. I am thankful for the collaboration of University of Leicester and Yashoda Hospitals for providing me the opportunity. Below mentioned is my email for any queries. Thank you, sir.
Thank you very much, Dr. Nitesh, and well done for covering such a huge volume of material in such a short period. Hats off to you. As you've clearly sort of said, it's important to be aware we've had some excellent talks this afternoon and covered a large area of COVID management in a short period of time. You may not seem it, and well done to everybody for hanging around. But obviously this is a rapidly evolving field. As you've said, there's a lot of evidence going on, so it's important people keep up to date. Obviously what we present today is only what's valid now. And it's important to sort of keep up to date as things change. I'd like to thank the whole faculty for their time and taking time out of their busy day today to participate in this. And I hope it's been useful to colleagues wherever you're listening around the world, including obviously colleagues in India, where we empathize with what the current situation there is. I just have one disclaimer slide to share with you from one of the earlier talks, which I hope you can see right now. I don't know if Dr. Haldar is on for him to chip in, otherwise I can do so.
No, thank you, Rakesh. Yes, so I have a disclaimer on one of the slides that I presented, which actually referred to our anticoagulation guidance here locally prior to publication of the REMAP-CAP studies. And so you'll remember that in the REMAP-CAP studies, they showed that therapeutic anticoagulation in people who were admitted to the critical care unit, therapeutic anticoagulation was not beneficial and not superior to prophylactic anticoagulation. And in contrast, people who had severe COVID who were not admitted to intensive care, the benefit seemed to be in therapeutic anticoagulation. So for that reason, following the publication of that study, our guidance locally did change. However, my slide did not reflect that. So our current guidance is sort of summarized here. So we treat people with severe COVID on the wards with therapeutic dose anticoagulation with low molecular weight heparin if they haven't previously been on an anticoagulant for a comorbidity. If they have, then they either stay on that or they go on to an oral anticoagulant such as rivaroxaban. And in that population, Anticoagulation may be continued after discharge if there is felt to be an ongoing risk, for example, if they're old and frail and likely to be immobile for a significant period. And similarly, in patients who are on the intensive care unit, the guidance hasn't changed, and we continue to treat them with high-dose prophylaxis. But of course, that may change once further data becomes available. Thank you.
Thanks very much for that, Pranab. We've sort of decided to ditch the Q&A session, I think, in the interest of time. It's been a long afternoon, and well done for those who've managed to last the whole 4 hours. This will be available on YouTube to refer to and look back at the talks. We've had a number of excellent talks, and once again, I'd like to thank the faculty for taking time out in their busy schedules to do this today. I know it's very late in India, and we'd like to thank Yashoda Hospitals for inviting us to do this afternoon. It's been great collaborating. Hope we can work together again. I know Dr. Harikishan's also been very busy in the ICU this afternoon. So well done for sort of keeping things going in the background. Dr. Harikishan, did you want to mention anything?
Thank you all the faculty from the University of Leicester for accepting the invitation and staying too long for this webinar. And we'll be doing the second series on infections and therapeutic aspects, where most of the intervention pulmonary aspects come, and then maybe you can see me and Rakesh talking on bronchoscopy in COVID-19 patients soon. And once again, thank you everyone, and all the people who are watching out there. Thanks for staying there for a long time. Have a very good night.
If anyone's got any questions, then please forward them to Dr. Harikishan, and we, the faculty, will be very happy to answer them at a later stage. So thank you very much, and good night to everybody in India, and good evening to everybody here. Thank you very much. Bye-bye.
Bye-bye.